Welcome everyone. Welcome everyone. Corinne, you can start with your welcome, and then we'll get started.
Hi everyone, my name is Kehan Kabambi. I'm the Assistant Project Manager with the New Jersey Birth Equity Funders Alliance, and we're really excited to have everyone join us. I'll pass it over to Cecile.
Fantastic. Yes, I'm so excited about this conversation today. So good morning, everyone, and welcome to our conversation. My name is Cecile Edwards, and I'm the Senior Manager of the New Jersey Birth Equity Funders Alliance. I will say NJBEFA from this point forward. The Alliance consists of 6 funding partners, and we come together in the spirit of collective commitment and action, leveraging our strengths and learning and unlearning ways in which philanthropy can be an authentic partner to support families, communities, the public sector, and community-based organizations in the goal of achieving full birth equity in New Jersey. Today, we're activating our guiding principles of community-first approach, collaborating, learning, and co-design. Today's learning session seeks to provide critical information into birth equity needs in the state of New Jersey. As many of us know, New Jersey was 47th in the state for Black maternal and infant mortality. And though the state has changed ranking to 36, these numbers do not reflect an improvement in Black maternal mortality. In order to positively move the numbers for Black mothers and families in New Jersey, we seek to determine what may be some areas that require more focused attention, investment, advocacy, and education. A landscape analysis commissioned by the Alliance showed that New Jersey birthing people of color face significant gaps accessing programs and services addressing social determinants of health. The community-based organizations focused on birth equity interviewed for this research reported high demand for housing, transportation, legal and language assistance services. Addressing these underlying causes of poor maternal health and maternal deaths will require cross-sector collaboration to better serve birthing people and their families. Just to level set on what social determinants of health are, I know that many of us probably already know, but it is defined as the non-medical factors that influence health outcomes. They are conditions in which people are born, grow, work, live, and age, and the wider set of forces and systems shaping the conditions of daily life. These forces and systems include economic policies and systems, development agendas, social norms, social policies, and political systems. Today, I'm thrilled for us to come together to learn, discuss, and use our collective brain trust to consider how we can use this information and resources to make New Jersey the safest place for Black moms to give birth and raise children. I want to extend gratitude to our funding partners, our Community Advisory Committee, our colleagues, our Nurture New Jersey Director, Rhea Rodney, and grantee partners that are champions of this work now and in the future. So just to give you a little run of the show and what we're going to do today, we are going to have presentations in our first section by Linda Locke, founder and executive director of the New Jersey Health Cares About Domestic and Sexual Violence Collaborative, and Erika Kerber, Esquire, president and executive director of the Community Health Law Project. Then we will go into breakout rooms. Then we'll come back together in the general room to share out what we discussed in the breakout rooms. Then we'll have a light break for 15 minutes just to gather ourselves, grab some lunch or breakfast or whatever. And then we'll have Alex Strapoli, Director of Advocacy and Communications at the Fair Share Housing Center. Jaye Wilson, founding president and CEO of Melinated Moms, will discuss transportation. Then we'll break out again, share out, and then we'll have our closing remarks. So that is the run of the show for today. And I'm happy to have our first presenter, Linda Locke, start the presentation today. Thank you, Linda.
Good morning, everyone, and thank you so much for having us, having me to speak with you this morning. So before we start, I understand that this is a difficult topic to discuss. When you see the statistics, you will see that this is a very common problem that we have in our nation, in our state. Intimate partner violence is a very common issue that many of us have dealt with. This is Domestic Violence Awareness Month, so it's really appropriate that Cecile asked me to speak with you this morning. So I just want everybody to take a nice deep breath, ground themselves in their chair or on their couch or wherever you are, and understand that it's really important for you to take care of yourself as you go through this, as we go through this presentation. If you have a moment that you need to step away, take a deep breath, please do that and take care of yourself as we go through this presentation this morning. So Cecile has already given us this idea about, the social determinants of health. And what we realize is that healthcare really impacts about 20% of our outcomes. And that the great majority of the things that have an impact on health outcomes are those social determinants of health. And she went through the social determinants of health that we think about: childhood experiences, housing, education, social support, family income, employment, communities, access to care. And those are the things that we generally think about, right, when we talk about the social determinants. When we're looking at maternal health, we need to realize that it's a continuum, not just pregnancy, but preconception, pregnancy, postpartum, and interconception. And as early as 2012, over 10 years ago now, the WHO Global Consensus Report on Preconception Care to Reduce Maternal and Childhood Mortality and Morbidity included intimate partner and sexual violence as areas for intervention to assure best outcomes. So what is IPV? Intimate partner violence is the more inclusive term. Domestic violence is the term that has been used, and it's used in the legal sense, but IPV is a more inclusive term that's used by most national platforms. And it's defined as a pattern of assaultive and coercive behaviors, including physical violence, psychological abuse, sexual violence, stalking and psychological aggression, intimidation, threats, enforced social isolation, economic coercion, and reproductive coercion. And it's to gain power and control over the victim or survivor. And the numbers are staggering, really. About 1 in 3 women report having experienced severe physical violence from an intimate partner in their lifetime. About 1 in 5 women have experienced contact sexual violence by an intimate partner. And 14% of women report having been stalked by an intimate partner. And this means that almost half of women and more than 3 in 5 men have experienced contact sexual violence, physical violence, and/or stalking in their lifetime. So the tagline for Domestic Violence Awareness Month is "Everyone Knows One." So the power and control wheel really identifies how violence plays out. And when we look at those statistics, and we're talking about the numbers are actually, I think, about 48.7% of women who report having contact sexual violence or physical violence or stalking. We have to understand that the aspects of intimate partner violence are not just those physical ones. Emotional abuse, intimidation, isolation, economic abuse, neglect, maintaining dependency, and threats of violence are things that aren't really reflected in those numbers. So if we include all of these, those numbers are much higher. And when we talk about sexual violence, that's defined as a sexual act committed or attempted by another person without freely given consent, or against someone who is unable to give consent. And that includes someone, it's forced or alcohol or drug facilitated, sexual touching, non-contact acts of a sexual nature, or forcing a victim to engage in sexual acts with a third party. Rape is more specific, which talks about penetration, And, there are a lot of myths around sexual violence as well as around domestic violence. And one of those is, it's a stranger. And we know that this is really a myth. The perpetrators are most often known to the victim or survivor, a friend, family member, or intimate partner. So through my talk, I will use the terms victim and survivor interchangeably. I want us to understand that is a self-definition that people who have had these experiences need to define for themselves. It's a journey to travel from viewing yourself as a victim to viewing yourself as a survivor. And this is something that needs to be self-defined. Reproductive coercion is a form of sexual violence that involves exerting power and control over reproduction, either through interference with contraception use, with pressure to become pregnant, with pressure to end a pregnancy, anything that is coercive around reproduction and pregnancy is reproductive coercion. Another myth is that if you're married to someone, it can't be sexual violence, but spousal rape is recognized in every state in the nation since 1993. And the statistics around sexual violence, about 1.9 million women each year will report rape, and we know that more than 50% are not reported. But even with that, every 98 seconds, someone in the United States is sexually assaulted. 1 in 2 women and 1 in 5 men have experienced some type of sexual violence in their lifetime, and 1 in 4 women has experienced childhood sexual assault. 20 to 25% of college women experience sexual violence before they leave college, and 60% of those assaults occur in the residence halls. So what is an intimate partner? Well, the CDC defines an intimate partner as a person with whom one has current or prior close personal relationship, characterized by emotional connectedness, regular contact, physical contact, and/or sexual contact, familiarity, and knowledge about each other's lives. So that could include a spouse, a dating partner, or a sexual partner. Excuse me. And physical violence is intentional use of physical force with the potential for causing death, disability, injury, harm, or coercing another to commit such acts. So who is vulnerable to either domestic or sexual violence, to IPV? Well, first of all, everyone is. There's no part of our community, there's no part of our state that is not vulnerable to having these experiences. It cuts across all types of people, every socioeconomic class, every race, ethnicity, every community. However, there are some people that may be more vulnerable because that vulnerability makes them more likely to be controlled and coerced by an intimate partner. People with disabilities may have less control over their ability to leave. And when we talk about disabilities, we're not just talking about people who are disabled or differently abled. We want to include people who are deaf, hard of hearing, people who are blind, people with physical disabilities, people with mental disabilities, people who are neurodiverse. So perpetrators utilize this, and sometimes these people are seen as less believable. People with other kinds of health issues, either physical health issues that make them more vulnerable, or mental health issues. And people with mental health issues, those issues are often used by perpetrators to infer that they're not believable, or to say, well, you're not, threaten them with taking the care of their children away. It occurs in LGBTIA+ communities. And for immigrant people, perpetrators will use their status as a threat to exert control. And sometimes people will be feeling isolated because they are now in a country with which they are unfamiliar. There may be language issues, which many of us are familiar with. And, the kind of situation we're in right now, with this very strong focus on immigrant issues, people feel much more vulnerable. And also, when I talk about intersectionality, we have to think about the different identities that people hold, right? Our people that are we know that those of us from marginalized communities that do not have good relationships historically with police and police systems, are often, these things can often also have an impact on how domestic violence, intimate partner violence, and sexual violence play out. So when we think about IPV, we think about power and control, and we think about people needing to get away, and we need to help people to navigate that relationship so that they can be safe. But what I want to also focus on is that there are a lot of injuries, both physical and mental, from having this experience. And for physical injuries to the head and neck are the most common, about 90% of all injuries. And this picture is what we kind of think of, right? Just somebody with a black eye. But there can be a lot of other different types of injuries, especially dental injuries like fractured teeth, which can cause bite problems and tooth abscesses. And dentists actually take training in how to recognize injuries from domestic violence because this is such a common thing. Another issue is strangulation. This is a significant predictor for future lethal violence. If a person has been strangled, it increases the lethality risk 7 times. So the difference, we hear, well, they choked me. So just to be clear, choking is obstruction of the airway by something internal. So that's, a piece of food obstructing the airway, that's choking. Strangulation is external. So someone putting their hands or a scarf or something else around the neck. The neck is the most vulnerable part of the body. Occlusion of the vessels in the neck only take about 6 seconds. And when we think about the amount of pressure that's needed, the amount of pressure that we use to open a can of soda is about 20 pounds of pressure. It only takes about 11 pounds of pressure to block the carotid artery and therefore obstruct oxygen to the brain. So when a person loses consciousness because of that occlusion, those are lost brain cells. Symptoms may take weeks or to develop, and up to 50% of people will have no external signs, but there can be delayed fatal or near fatal consequences of strangulation. So IPV and traumatic brain injury. When we think about traumatic brain injury, what do we think about? We think about the military. Perhaps we think about football, concussions, right? We think about even automobile accidents. But domestic violence is a primary cause of traumatic brain injury for women, especially, and for men, but we see it mostly in women from this particular issue. So it's defined as a closed head injury or cutting off oxygen, and it can range from mild to severe. And victims are often not aware, especially if they did not lose consciousness or did not go to the emergency room, and many do not. But we also know, just like in football, repeated injuries cause cumulative effects. So IPV in pregnancy We know that reproductive coercion can affect decision-making about pregnancy. We can also see that people that are in these types of relationships will often have delayed onset of prenatal care and missed visits. There's an increased risk of spontaneous abortion, preterm labor, low birth weight, anemia, poor weight gain, infections, labor complications, worsening of chronic conditions, and other poor pregnancy outcomes. There's lower breastfeeding rates, more PMADs, perinatal mood and anxiety disorders, increased rates of perinatal injury, and indirect effects to the fetus from maternal stress, which we now know may have long-term impacts on fetal and infant development, and possibly negative maternal coping behaviors, smoking, alcohol, or substance abuse. Domestic violence often escalates with the onset of pregnancy. The risk of physical violence doubles. And pregnancy does not protect the mother from partner homicide. In fact, homicide is a leading cause of traumatic death in the pregnancy year. Pregnant women in the United States are more than twice as likely to be murdered during the pregnancy or shortly after childbirth than they are to die from the three main medical causes of maternal death associated with childbirth. So it's more likely that a person dies from homicide, most likely from an intimate partner, than from hemorrhage or hypertension. And Black women are 3 times as likely to be killed by their intimate partners around the time of pregnancy compared to white or Hispanic women. So for those people who have had intimate partner violence injuries in the past, they now enter the pregnancy perhaps with traumatic brain injury. How does that affect their daily life? There are long-term health effects. There can be problems with vision, problems with increased cognitive issues. There are problems with memory, with motor, with sensation, and sleep disorders. And there's an intersection of IPV, mental health, and TBI. We know that people who have experienced IPV have increased rates of depression, anxiety, PTSD, substance use disorders, eating disorders, suicidality. But is it depression or is it TBI? And so the PHQ-9 is something that we use often to screen for depression, but there is overlap in some of the symptoms that we identify as depression. If we don't know that this person has had a brain injury, we might say that it's depression and not realize that there's another component. The same for PTSD. Many survivors will have PTSD, which is not a surprise, right? If you have experienced this kind of trauma, PTSD is post-traumatic stress disorder. However, again, there is an overlap between the symptoms of PTSD and TBI, both of which or either of which could be possible for a person who's had this experience. And how does having the experience of IPV impact the intersection with our healthcare systems? There can be fear and anxiety which factor into disrupted utilization patterns, issues with follow-up that can relate to a survivor's difficulty with trust and authority, or with partner controlling their ability to follow up. Sometimes benign experiences like history taking may activate disturbing memories. There may be systems barriers, long wait periods in waiting rooms, questions by scheduling staff in front of a full waiting room of people, and home may not be safe. Where was their violence experienced? For reproductive health care, there are many, many GYN symptoms and increased anxiety with exams. Over 40% of sexual violence survivors report having flashbacks during their GYN exam. Think about the power disparity, the positioning, the necessity to relinquish control, and the discomfort of a pelvic exam. In pregnancy and childbearing, we know that there are heightened, intense feelings we all have during pregnancy. And sometimes survivors, the body changes of pregnancy renew a sense of disempowerment. Oops. Sorry about that, folks. Hit the wrong button. So when we think about labor and birthing, many of the childbirth practices that we see in hospitals can be re-traumatizing. Loss of control is a major issue. People may not trust their caregivers or herself. People may lose trust in their own bodies to birth. Labor experiences and sensations may activate memories and fears. There may be issues around pain relief. Labor styles can be fight or take control or surrender or retreat. People need reassurance of safety to stay in the present and be assured that their issues can be revisited after birth. Postpartum issues may surface. There are higher rates of perinatal mood and anxiety disorders, especially depression and anxiety. Common procedures in hospital settings can be activating. Think about peri-checks. Think about breastfeeding assistance when people come in and touch the survivor's breast. Breastfeeding that may activate old fears or stimulate new ones. Survivor moms of baby with the same sex of the perpetrator may have difficulty with breastfeeding and bonding. Survivor moms of girls fear they can't protect their daughter. They may have trouble watching an infant exam. I had one young woman who cried because some of you are familiar with the motion that you do to check for hip dysplasia with a baby, and that just made her go into tears because it activated memories of sexual violence. So it's really important that we understand that many of our patients and clients have had these experiences. And so that brings into play the need for trauma-informed care. And SAMHSA defines trauma as resulting from an event, a series of events, or a set of circumstances that is experienced by a person as physically, emotionally, or harmful or life-threatening and has lasting adverse effects on their functioning, either mental, physical, social, emotional, or spiritual. So the framework for trauma-informed care is both in interactions between the professional and the patient, but it also needs to be incorporated into our systemic culture. The 3 E's of trauma look at those that I just identified: the events, the experience, and the effect. And the 4 R's of trauma-informed care are that we realize the widespread impact of trauma and understand the potential paths for recovery. We recognize the signs and symptoms in our patients and clients and our staff and others involved in the system. And we respond by fully integrating this knowledge into our practice, policies, and procedures. And we resist re-traumatization. So re-traumatization can occur, like I described those situations before in labor and postpartum, but can occur in any particular part of the healthcare system, where the medical power and control wheel identifies how the medical care system can re-traumatize survivors by trivializing or minimizing the abuse, not respecting their autonomy, blaming the victim. Why don't you leave? Why do you put up with it? Why do you let him do that to you? Ignoring the need for safety and violating confidentiality are some of the ways that the medical system and the healthcare system can re-traumatize victims. And we need to be aware that any person who presents may have a trauma history. It may never have been disclosed, and it may have been disclosed in the past, and sometimes that disclosure was not met well. Services may have been inadequate or inappropriate. So we need an environment of care that is sensitive to this knowledge, inform before we perform, offer people options, take histories while people are dressed, make sure we respect people's need for privacy, avoid phrases like just relax, get consent when we touch people. So Futures Without Violence has an evidence-based intervention which addresses domestic and sexual violence and human trafficking for healthcare settings. And the key thing for this is universal education. And it really looks at, that many of our organizations have discussed how important it is to have universal screening for IPV and for our patients, which is absolutely an important piece. However, universal education goes a step beyond that. And why is universal education important? Because it looks at it honors equity. If we look at what we mean by equity, that means that everyone gets the resources that they need, and that we recognize that people know what they need. We are not the gatekeepers of deciding who gets what information, but we understand and respect people's knowledge and their ability to assess their own lives, be experts in their own lives. And so this is why universal education really supports equity. So the SAFE framework was developed by New Jersey Healthcare's About Domestic and Sexual Violence to be a framework for addressing our patients who've experienced IPV and sexual violence. Share, screen, and support, assess, facilitate referral and recovery, educate, and empower. And again, sharing information about domestic or IPV and healthy relationships with all our patients and clients, in addition to screening all patients in private. Why is this so important? We know that many people are not going to share the information with us. Even if we screen all of our patients, people who quote unquote screen negative may actually have had these experiences. They may not be in a place where they're ready to trust us for a variety of reasons. We know that many of us have had difficulty with systems and are now reticent to share information that we think might bring on a referral to Child Protective Services, a referral to police. And so we don't share that information with caregivers. So besides screening, sharing information, universal education is really important, and then supporting people where they are. The next is to assess, acknowledge, and assist. So if people do disclose this information, we should have an empathetic response, assess for current safety, assist with beginning of safety planning, and acknowledge there can be an impact on health. Think about somebody who has had repeated head injuries and has some TBI symptoms, and that person thinks they're crazy because they're having these symptoms, and the perpetrator may be saying to them, "You are crazy." How would that person feel if you explain to them that sometimes people who've been injured from an intimate partner will have had an injury to their brain, and they may have some symptoms like the ones you're describing to me? Confidentiality. Who will access this information? Know what your limits are and requirements are as a man, and think of yourself as a mandated supporter, and assess the health effects, physical assessment, need for emergency room or other referrals, and connect their experiences to their symptoms. Now, facilitate referral referral and recovery, provide referrals to resources, both IPV resources and health resources, know our internal resources and policies. Every county in our state has both domestic and sexual violence resources, so become familiar with those in your community. There are additionally culturally specific resources that can be very helpful for survivors. Warm handoffs we know are always best, and possibly medical or mental health referrals. Review their prior experience before giving a referral. Have they been to an agency and that didn't go well? So that's not where you don't want to send them back there. And acknowledge the need for readiness, present options, and leave the door open to talk another time. Empathetic support facilitates healing. And then educate everyone, encourage empowerment, and validate people's experience. It was brave of you to share this information with me. Encourage people to self-define their experience, listen, believe, and support their autonomy. You are unique, but you're not alone, and you are not to blame. Use shared decision-making. Again, people are experts in their own lives, and they know what is safe for them. Remember, it is not our goal to get people to leave. We want to remember that when people leave or even are preparing to leave, that is the most dangerous time. So we want to be very sensitive to people's knowledge about what they need to keep themselves safe. We do know, however, that people and survivors who do talk to their healthcare provider are 3 times more likely to use services. And whoops, I'm sorry. These are resources: New Jersey Coalition to End Domestic Violence, and New Jersey Coalition Against Sexual Assault. The Brain Injury Alliance of New Jersey has a whole section on domestic violence and traumatic brain injury, and then national organizations as well. Thank you.
Thank you so much, Linda. I've heard this presentation before, and I always hear something new, and I absolutely appreciate this. There is a few things that struck me, in one of them is that homicide is the leading cause of death in pregnancy, that is above hemorrhage or hypertension for pregnant women, pregnancy-related cause. That really struck me and continues to strike me as a issue that women are dealing with, families that are dealing with. So Linda's bio is in the chat, so please feel free to look at that. Erika Kerber has been with the Community Health Law Project for over 19 years. Moving up the ranks within the organization. She began her career at CHLP, first as supervising attorney of its Mammoth Ocean office, then as the managing attorney of that office. She then moved up to director of litigation and then associate executive director, to ultimately being appointed the new president executive director in January 2022. Congratulations. Prior to joining CHLP, Ms. Kerber practiced law at Northeast New Jersey Legal Services. She litigated child welfare cases while working for the city of New York and spent some time in private practice. She sits on the board of the New Jersey Association of Mental Health and Addiction Agencies and the New Jersey Mental Health Institute. She's also a member of the New Jersey Mental Health Coalition, the New Jersey Professional Advisory Committee of the Division of Mental Health and Addiction Services within the Department of Human Services. And she sits on the Leadership Council of the New Jersey Statewide Network for Cultural Competence. Ms. Kerber received her law degree from the Benjamin N. Cardozo School of Law and her bachelor's degree from NYU Leonard and Stern School of Business. Welcome, Ms. Kerber. I'm looking forward to your presentation.
Thank you so much for that introduction. Wow, I'm exhausted. There's a lot. I've been doing a lot. Thank you so much. And I think my presentation, is a good segue to Linda's presentation, because I'm going to discuss legal issues. And one of the legal issues that we obviously can address are domestic violence. So I'm going to share my screen. Can everyone see that? Okay. Let me start. Okay, I think I'm just going to leave it as is. So this morning, I'm going to talk to you about medical legal partnerships to improve maternal and child health. My organization, the Community Health Law Project, we've been in existence for over 45 years. And we provide legal assistance to individuals with disabilities, chronic health conditions, and the frail elderly. We have offices statewide. And in recent years, I've done a lot of research on medical legal partnerships, and we have developed medical legal partnerships with healthcare providers. But specifically this morning, I'm going to talk to you about how medical legal partnerships improve maternal child health. So Cecile and Linda already talked about social determinants of health. That's what we're talking about this morning. Common social determinants of health we know are income and health insurance. Individuals need resources to meet basic daily needs in healthcare. Housing and utilities. Individuals need a healthy physical environment. They need quality education and job opportunities, access to public entitlements and jobs, and of course, personal and family stability, safe homes, and social support. How do social determinants of health affect health outcomes? Cecile already mentioned that 80% of a person's health is determined by social determinants of health, while only 20% is impacted by clinical care. And this is a telling statistic. The US spends more money on healthcare than any industrialized country, but it ranks 42nd in life expectancy and 169th in low birth weight. These poor outcomes are the result of where the money is spent. Other first world countries with better outcomes spend $2 on social services for every dollar they spend on healthcare, whereas the United States spends 90 cents on social services for every dollar it spends on healthcare. So we are behind many first world countries in this area, and we need to do a better job. So what are examples of legal assistance addressing social determinants? So what do? We're talking about civil legal issues, not particularly criminal, but civil legal issues run the gamut of all types of issues, fighting unlawful evictions. Alex is going to be talking about housing. My office represents individuals in eviction matters, voucher terminations, deplorable housing conditions that affect everyone. And of course, specifically today, we're talking about young moms and birthing moms. Also, forcing landlords to comply with building or health codes. This is relevant to what Linda was talking about. We assist victims of domestic violence with restraining orders to keep themselves and their children safe. So when they're ready, I myself have handled many of those types of issues representing victims of domestic violence and getting those final restraining orders, and also dealing with not only that, but you're dealing with many other aspects. Child support, visitation, custody issues in those areas. Another aspect of legal services, workers needing protection from unsafe or toxic working conditions. Of course, access to entitlements and food stamps. So when individuals apply for public entitlements and food stamps and they're denied, they really should have an advocate or an attorney represent them in appealing those denials or appealing those terminations. And of course, health insurance coverage issues. If individuals don't have health coverage, they're not accessing the health care that they need. So according to a recent study in 2017, 71% of low-income households experienced at least one civil legal problem, including problems with healthcare, housing, disability access, and domestic violence. So that's a staggering statistic. My office assists, again, when we're talking about individuals with disabilities, chronic health conditions, and the frail elderly, over 5,000 individuals every year. And the need is much greater than we can provide, than the services that we can provide. So what are medical legal partnerships? I talked about how legal services can assist with the social determinants of health. And in the last, historically, individuals come to our office, they're referred by a healthcare provider, by a family member, by a state agency. They get to our office and many times they're in crisis, right? They're already evicted. They lost their housing voucher, and our options are very limited at that point when they're in crisis. However, medical legal partnerships are a way to work with healthcare providers to work proactively, to really address these issues proactively instead of reactively. So medical legal partnerships are partnerships between healthcare providers and legal service providers, where attorneys are embedded as specialists in the healthcare setting. We're really looked at as part of the healthcare team to strengthen the social determinants of health among low and moderate income patients using the force of law. So it's integrating civil law attorneys into the healthcare setting. Attorneys are training healthcare workers to screen for health harming legal needs, not only screening, but really providing trainings in all types of legal issues. When problems are found, like unsafe living conditions, these problems can be addressed preventively through the in-clinic attorney. So for example, when someone is assessed for, if they have issues in terms of safe housing, and then they report that they haven't paid their rent in a couple of months, but they haven't been served with an eviction complaint, that's really when an attorney needs to get involved to really try to address that issue. And a lot of times what we find out is that, trying to get to the root of the matter, an individual hasn't paid their rent, either maybe they have a child support obligation they can't afford to pay, or they're being garnished, their income is being garnished and they can't afford to pay their rent. Those underlying issues also have to be addressed in order to resolve their rent issue. Another aspect to medical legal partnerships, it allows doctors and lawyers to work together to help patients by strengthening legally protected social supports. So this is a very novel issue, right? Doctors and lawyers working together. Doctors are apprehensive of working with lawyers. Every time they hear about a lawyer, they think, oh, am I going to be sued? But it's really working together to help the patients. The other aspect to this too is that, patients, consumers, clients can be referred to our office. They may not get through our door though. And we're always wondering, well, an agency referred them, where are they? Because there is an apprehension when some of our clients, they think lawyer, they think, am I going to jail, right? If they've been involved in the criminal justice system. So they're reluctant to come through our doors because they think they're going to get in trouble. So with a medical legal partnership, it's really a warm handoff. We're working together with the healthcare provider, and the patient understands that. And it's explained that, what this attorney is here to help you. And another aspect is some partnerships leverage their knowledge and expertise to advance local and state policies that lead to safer and healthier environments. For example, if we find lead issues in many apartments in one area, we can really advocate for policy change or advocate for system change, to deal with those landlords that are doing this, and to deal with the housing codes. Okay. Moving on. So I talked about medical legal partnerships. There's been studies done that show that when legal expertise is used to address social needs through medical legal partnerships, individuals with chronic illnesses are admitted to the hospital less frequently. People are more likely to take their medications as prescribed. They report less stress. Less money is spent on healthcare services for those who would otherwise be frequent users of hospitals and healthcare systems. And clinical services are more frequently reimbursed by public and private payers. So we're talking today about maternal and child health. So how specifically does medical legal partnership help in this area? A pregnant woman living in poverty faces stress that often has negative consequences for her and her baby's health. And Black and brown women and their children are statistically at an increased risk. Unmet housing needs, lack of access to quality health care, financial insecurity, immigration status, and family stability are just some of the social determinants of health affecting these pregnant women. Many of these stressful situations require legal aid. So as I mentioned earlier, my organization has developed several medical legal partnerships. We have medical legal partnerships with behavioral health providers, addiction treatment providers, HIV/AIDS treatment providers, but specifically for this population that we're talking about, we have developed medical legal partnerships with Horizon Neighbors in Health program, which utilizes community health workers. And in that program, we have assisted several pregnant moms with a myriad of issues, housing related, public entitlements, domestic violence, those types of issues. We also specifically have medical legal partnership with a provider in Warren County. Center for Family Services is a statewide organization, but specifically with their Warren County office, we have a partnership with them through their integrated opioid treatment and substance exposed infants program, which provides a comprehensive array of services for opioid dependent pregnant women, their infants and families. And we are their partner to provide legal services for their consumers in that program. So we talked about what medical legal partnerships are, but specifically besides these programs, there outside of this, I'm not aware of any medical legal partnership specific to addressing maternal child health. I know the Camden Coalition has done some work there, but other states are doing a much better job than New Jersey. So I'm going to talk about other states and how we can learn from them. Well, so it's Washington, D.C., not a state, but the District of Columbia has a very robust perinatal law project. It's a medical legal partnership between Georgetown University Health Justice Alliance and the MedStar Washington Hospital Center, Women's and Infant Services, and it addresses health harming legal needs in an OBGYN practice. They analyzed data for the first 18 months of the program. 131 patients were referred for legal services primarily by social workers and health navigators. Most of these patients were in their second or third trimester. The majority of the patients were African American between 20 and 34, and they lived under 200% of the federal poverty level. They addressed 150 legal issues and served 117 patients. And this is pretty universal throughout the most common legal issues because there's the greatest need in these areas: employment, parental leave and discrimination, housing conditions and eviction, public benefits, food stamps and disability benefits, family law, domestic violence, and child support. In these initial 18 months, the partners concluded that the medical legal partnership was an effective approach to addressing maternal health disparities. Moving on to California. California developed their maternal medical legal partnership in 2018 between legal aid attorneys and the Equal Justice Works Fellows and a nurse family partnership. And you're going to hear this throughout in terms of other states. It's very common to have a nurse family partnership or nurse legal partnership where attorneys are really working with the nurses who have more contact many times with these patients. And it was to address social determinants of health of low-income mothers in Los Angeles. The nurse family partnership provides physical and mental health care to low-income pregnant and postpartum mothers through a home visitation model. And the medical legal partnerships works with them to provide direct legal services. And here, in an initial study of the medical legal partnership, the needs that were identified were 27%. The majority were domestic violence and child support, employment, pregnancy-related accommodations, just as breastfeeding and other work accommodations, housing, evictions and habitability, and immigration, legal status, and public entitlements. There was an over 70% screen positive rate. That means over 70% were screened and determined that they needed legal assistance through this medical legal partnership. Moving on to Delaware. They started in 2013. It was a pilot project between the state agency, Delaware Division of Public Health, and the Delaware Community Legal Aid Society worked together. So here the state was directly involved with support from other organizations. And in Delaware, the medical legal partnership works as a referral system from the healthcare provider to legal services. The providers are trained in how medical legal partnerships improve health outcomes and how to refer to the legal partner. Clinicians and social workers, so here they use a questionnaire. And for pretty much all of the medical legal partnerships, what we use is it's either a questionnaire, we call it here a legal screening tool, an assessment. It's really a tool to really assess what the legal needs are potentially. But here in Delaware specifically, they gave their patients a questionnaire called the Perceived Stress Scale to assess anxiety and stress levels and obtain additional information about stressors during the patient visit. based on what the patient reported. If appropriate, the patient was referred to the legal partner. And here the participants reported an improvement in mental and physical well-being and lower levels of stress. Pennsylvania, similarly here, it was a nurse legal partnership started in 2016. Lawyers with expertise in public benefits, housing, consumer, and other areas of poverty law collaborated. And the attorneys here working are really attorneys who are expertise in poverty law. And when we're talking about poverty law, we're talking about all these issues: income supports, housing, education, domestic violence, those types of issues. And they use the acronym IHELP to help them assess for legal needs. IHELP, self-explanatory: income supports, housing, education, legal, immigration, personal and family stability. And, you know, I'm going to talk a little bit later about how these medical legal partnerships are funded, and they're funded through different funding streams. But here it was funded through multi-year grants from local, national, and international funders. So there really has to be an investment in funding these medical legal partnerships. Texas. In Austin, People's Community Medical, there was a clinic, medical legal partnership. They created a legal checkup to help pregnant women in Texas. And here they did something a little different, where they created videos for patients to watch that cover different issues, including health insurance, food security, domestic violence, employment, housing, healthcare, parental rights, and breastfeeding rights. In addition to the videos, the attorneys in the medical legal partnership are embedded on site at the clinic and attend group medical visits and address patients' legal issues. So I also want to talk to you about, so not only are these attorneys in the medical legal partnerships providing direct legal services, I talked about trainings to build capacity with healthcare providers, but also when healthcare providers have team meetings, weekly, bi-weekly, monthly, when they're talking about patients, those attorneys need to be involved in those discussions. In several of our medical legal partnerships, we're very, very engaged, where not only do we talk about the status of their legal issue, but we also hear from the healthcare provider about what's going on the clinical side, because we're all intertwined. All these issues are intertwined. The clinical, healthcare, legal, all these issues really affect that whole person care that we're talking about, and we all have to work together. So it's imperative that we're part of those team meetings as well. And here in Texas, the patients reported less stress and increased legal literacy to help empower themselves to better understand their rights. And the providers reported improved self-efficacy in providing whole person care. So moving on. So I want to talk to you about, this was actually a grant impact report out of Cincinnati. It was a 3-year grant for $874,000. And it was a medical legal partnership between Legal Aid Society of Greater Cincinnati, and it was a maternal health law partnership. And the priority was obviously to address maternal and infant health. And the outcome study showed some significant things. So the key accomplishments, like I mentioned, they created a legal screening tool. And here they screened 88% of over 3,000 maternity patients during the grant period. They referred over 800 patients for legal support. 900 patients were open to address health harming needs. Now they referred over 800, but how could there be 900 cases? That's because many clients will come in with one issue, but we address multiple issues. Okay, so like I mentioned, that individual who has a rent issue may be facing eviction. Why are they facing eviction? Because they can't afford to pay their child support. They may have been unable to work, right? They become disabled. They have to apply for Social Security disability benefits that they need assistance with. They've been denied several times, and they need an attorney to help them at their hearing. So many of these cases require, addressing several legal issues for one patient. And here also, they conducted 17 training sessions on a variety of legal topics. So the key outcomes that were found were, there was a 36% reduction in extreme preterm birth rate. 97% of cases were completed with an outcome that resolved the individual's social needs. And the estimated cost savings by preventing 18 extreme premature births found was more than $1 million. So not only are we really assisting individuals holistically with all their needs to ensure, that they improve their health and their baby's health outcomes, but there's significant cost savings here for the healthcare provider. So moving on, I talked a little about funding sources. So potential sources of funding for medical legal partnerships, foundation grants, government grants, subcontracts with healthcare providers. Several of our medical legal partnerships are through subcontracts. Providers apply for grants, and then they include us as a partner. We've applied for foundation grants, government grants. Also Medicaid financing models. Some states are doing this through Medicaid waiver opportunities, Medicaid managed care contracts. And, I know we're talking about our Medicaid 1115 demonstration waiver that is taking place right now. And I know there's an investment in maternal and child health, so we need to discuss including legal services in that area as well. And recently, North Carolina moved to managed care, Medicaid managed care. And what's interesting about North Carolina, when we looked at North Carolina, I just spoke to my colleague from North Carolina, an attorney there, about what's going on there. But the North Carolina Department of Health and Human Services released a request for proposals for Medicaid managed care prepaid health plans, which states that prepaid health plans are required to provide access to medical legal partnerships for legal issues adversely affecting health. And that's a huge recognition that health insurance companies, HMOs, MCOs, managed care organizations have to understand the value and provide access to medical legal partnerships, to legal services to address health harming legal needs. And we're looking at North Carolina very closely. They're really still at the beginning stages because this, there was a hold, a pause during the COVID pandemic, but we're looking at them very closely, and they're actually looking at us very closely too because of our Medicaid waiver. The Medicaid waiver includes legal services to address housing issues for Medicaid recipients, but we do need to look at legal issues to address more broadly at other populations and other aspects of social determinants of health. So that concludes my slides. And now I do have a 3-minute video that, again, I think is very impactful out of Washington, D.C., the D.C. model that I'd like to share. So I'm going to stop sharing my screen. And I think, Corrine, you can play the video, please. Thank you so much.
Through our work here at MedStar Health with the DC Safe Babies, Safe Moms initiative, we are working to create positive and sustainable change in maternal and infant health.
The initiative is an intentional focus to improving the conditions of maternity services in the District of Columbia.
This initiative has been made possible by the A. James and Alice B. Clark Foundation grant. It allows us here at MedStar Health to collaborate with our partners in Community of Hope and Mama Toto Village to address the maternal mortality conditions and the concern around infant care in Washington, D.C.
So the Safe Baby, Safe Moms program is geared to enhance the relationship that we can have with our patients. It's not just seeing the patients when they cross our threshold. We're looking beyond when they come to us. We're looking at what factors or what barriers that will prevent them from seeking care. It looks at housing. It looks at food insecurities. It looks at medical legal issues. So we're not sending people here and there. These people are in the office to see us. They see the social worker. They see the behavioral health team. They are put in touch with our medical legal partnership.
Our goal is to break down the barriers that patients may have and just connect with them a little bit better.
Well, I have a strong desire to make a change with, African Americans, especially in pregnancy. Patients voice how much they appreciate the support that's needed. I mean, I've had patients tell me recently, like, you have been a godsend. Good. So just wanted to follow up. I know you were seen in our office on the 16th.
1 in 5 to 7 women experience perinatal mood and anxiety disorders. So when you have a lack of support, you're dealing with depression or anxiety, you need more care. Behavioral health care is very critical because that increases the chances of the patients having a healthy pregnancy, having healthy parenting patterns.
Civil legal services for this particular patient population be a lot of housing, family law, employment, public benefits. Those are a lot of the legal needs that we've seen that are impacting them as a whole, their family and themselves. One of the most gratifying parts of this position is that I do have a way to make this change for them. Something that I think is so small, part of my day-to-day, but to them it means the difference between a healthy pregnancy, and one that is riddled with complications.
It's programs like this, these initiatives, that are going to start to make that change, to help to address these inequities and give every individual the equal and appropriate care that they deserve.
Okay, thank you so much. Like I said, I thought that was very impactful, just in terms of what we can learn from the District of Columbia and other states as well. So thank you.
Absolutely. Thank you so much, Erika. I appreciate the presentation. And as usual, every time I hear it, I hear something new and make new connections. And I love that, the connection between Linda's presentation on partner violence and your on the legal needs of for maternal care, maternal mortality, maternal and child health is just very clear. New Jersey, with all of the work that we are doing in maternal and child health and to eliminate maternal mortality among Black mothers, this is definitely an area that we can work to make more connectivity with and ensure that these partnerships exist for the health of families in the state. So with that, we are going to go into breakout rooms so that you have an opportunity to speak with the presenters more closely and sort of have a guided, semi-guided conversation to share your questions. I know there was a question for Linda in the chat, and hopefully that's addressed in the breakout room. So I'm going to leave it up to Corinne to usher us into breakout rooms.
Yep, I will be opening up the breakout rooms now, and based on the assignments that you chose when you registered. And we'll be in the breakout rooms for 20 minutes. I'll give you a heads up when we are at 5 minutes, and then we'll go back to the main room. Okay, opening them up now. Hi, everyone. I'm just posting a Google Doc. Posting a Google Doc for our breakout session that can kind of serve as some guiding questions for our conversation. But this is also a space just to ask any questions that you might have for Linda as well. Yes, just Linda, I know there's a question in the chat earlier, so I'm just reposting it here.
Okay, so the question, I'm not really understanding that question. So I think the question about people who've been assaulted in another state. So I think the key to that is what you mean by support, right? So there are a variety of different types of support, and my focus is on support within the healthcare space. Erika's more support within the legal space, right? And those are really two kind of different areas. So in the legal sense, interstate things, I really don't know. That's just not my area of expertise. But I think if somebody has that issue, connecting them with the local, so every state, every county has a domestic violence agency and a sexual violence agency, right? In some counties, they're separate. In some counties, they're together. So what's really important is knowing who your local agency is and being able to connect victim survivors with that agency. They will have the information around the legal aspects and what to do in that area, what's available for people. New Jersey really has some of the best laws protecting survivors of both domestic and sexual violence. We are a state that you can get a TRO, a restraining order for sexual assault as well as domestic abuse, and that's not true in every state. We have, as far as homicide goes, we have some of the best laws restricting perpetrators' access to firearms once there's been that conviction, so that there is a lot of, we have a lot of things going in our state. Oh, wow. Wow, Nicole. I'm so sorry that happened to you. I'm so happy you're surviving and thriving. And that you're safe here. Okay. Yeah. Brianna, you had a question? I see a hand.
Yes. Hi, thanks, Linda, so much for the presentation. I joined this breakout room because I feel like this is just a topic that's not talked about enough, especially when it comes to birth equity, but I just think in health overall. So thank you so much for your presentation. Yesterday, I was on Indiana Minority Health's Echo, and they actually spoke about domestic violence and how that looks in the hospital with a laboring person. And they did a case study, and the person who was presenting, I guess, was trying to find different routes to speak with the patient about their experiences. So they said sometimes they would try to bring the patient to the bathroom, but that can be a challenge because the partner might not even allow that. So my question for you is there any playbook, whether it's for New Jersey or the nation, for providers to use as a guide to help them talk with their patients independently of their partner being in the room or even at the facility in general? Because I feel like the providers need help. They don't know how to maneuver this sensitive topic. So just wanted to get some insight on that.
Yeah, and other people speaking. Jamie has a lot of knowledge in this area also. But I think so when we talk about policy level things, I think a policy level thing that needs to be for every institution and every place that's caring for people is that everybody, all adolescents and adults, will be seen alone for part of their visit, period. And that is a policy for the institution. And it's posted, right? So it's posted in the waiting areas. It's posted in a variety of spaces around the facility. And so this is the norm that everyone, because I mean, this we're talking about maternal health, but think about the elderly. I mean, like the person who is coming in with them may be the person who is abusing them, right? And so unless this is a policy throughout the organization for everyone, you're going to have these issues. You're still going to have issues, even if it's policy, because perpetrators, it's about control and they don't want to leave that person alone, right? So, which is a big red flag. But they'll say, well, they'll frame it in such a way that, well, we're this is my baby. We're all, we're together with this. And somebody asked me once, well, what about if her birth plan says we won't be separated? And I'm like, well, how do you know who told her to write the birth plan? If she wrote that birth plan at home, he may have, I'm saying he because it's predominantly he, but we know it could be she also. He may have probably did dictate what that birth plan was going to look like. So we need to have that as a policy level, because otherwise providers run into difficulty when they try to kind of, and I've been there, you're trying to sneak around and find a time to talk to this person without, somebody else in the room. And that's it. What can a professional do if the partner refuses to leave the victim's side? So there are some ways to so there are some things that I've seen used, and some other ways to get information to people. So one way to do it is, again, this universal education piece. Everybody gets information about everything, right? When we talk about shared decision making in the healthcare space, the whole purpose around shared decision making is that we as healthcare providers are not the gatekeepers of the information. We don't get to decide who gets what information, right? We don't hold on to the information and say, okay, well, I'm screening. And it's fine if we're talking about screening for diabetes, right? If your hemoglobin A1C is 8, okay, this person has diabetes. You do X, Y, and Z. But this is not that, right? This is not a clear cut kind of thing. So you give everybody information about everything. And we really got into that during the pandemic, where folks would put on the screensaver, as people got into the telehealth room, they put up all the information about all different kinds of resources. So if you need help with food, if you need help with housing, if you need mental health, if you need domestic violence help, these are all the resources. So you're giving people all these resources together, so the perpetrator can't say, well, why are they handing you, this about domestic violence? No, I give everybody information about everything, because you may not need it, but your friend or your sister, your cousin may need it, right? And there's 14 things, and we've been trained, we just need to give people what they need. They need to identify what they need. We don't identify what they need, right? So if I get a little excited about this, just bear with me. Bear with me. So that's one way. There are other ways. I mean, I've written numbers in a way that, like a phone number in a way that it doesn't look like a phone number. Like I'll write the numbers like this, or I'll write them backwards, or I'll write them in a strange way so that they don't look like a phone number. And we have 2 of the consortium, or maybe 3 now. I think Jamie is in Central doing the lipstick thing. Yeah, there's a lipstick project where there's this little tube that looks like a lipstick, but inside is not lipstick. Inside is a little paper with all the domestic violence information on it, right? Wow. Yeah, cool. That's very cool. It's been around for a long time, and it keeps kind of getting brought back up, like we get the money, people get the money. I think Central and Northern are both doing it now. So that is another way. And having information in places where the partner can't go. So not in labor and delivery is hard because they can go everywhere. But in the clinic or in your office, if you put it in the bathroom, he's not going into the bathroom, right? So the clinics and offices where I've worked at, we had information in the bathroom so that folks could get it. Jamie?
Yeah, hi. I wanted to make a couple points. So my name is Jamie. Again, say everybody, I work with Linda pretty regularly. I work for the Central Jersey Family Health Consortium. I'm a registered nurse, and I work with Linda doing maternal mortality review in the state. So that's my primary role. In another life, I was a crime victim advocate for domestic violence victims. I'm also a survivor. So I kind of speak with a lot of different lenses on this topic. So back to the first question, Linda, somebody had asked about like multi-state jurisdictional issues. So I'm thinking, for people who like live in Jersey and may have been assaulted in Philly, right? For instance, because that happens a lot around here, right? So, with proximity, or at least that's, kind of for me, or in New York or Delaware or whatever. But there's going to be, if there's a criminal case, typically nowadays, the criminal office will have, whoever's prosecuting that can typically offer like an advocacy service that can get you hooked up with people who understand the legal issues in the state specific to where the criminal case is going to be. Okay. So you might be receiving services socially through where you live, right? If you live in New Jersey and in my area, it's Burlington County. So it would be Providence House. So you can receive social services in New Jersey, but then you're also typically eligible because you were, victimized in another state. Their prosecutor's office, should hopefully have like a referral for a local resource that can help you understand legal advocacy. And they might even have legal advocates. I used to accompany people through the process of getting restraining orders, and if they had a criminal case, kind of going through that. So there's oftentimes multiple areas where that can be addressed. The other thing that Linda was saying, you answered basically like exactly the way I, right? Because we do this together. But, I think that it's really important to point out that it doesn't have to just be healthcare offices that provide resources for people. I was at a Phillies game over the summer, and there was a sticker on the mirror at the Phillies game. And I was like so excited about it that I took a picture of it and used it in a presentation, because you have an organization, where tens of thousands of people come to this, to a ball game, right? And they see something in the bathroom while they're washing their hands. There's a QR code on, and as we get to the point where, younger generations, 47 and beyond, childbearing, right? The younger people who are younger than me know how to use technology and how to be safer in a way that, maybe older generations don't. So let's provide them resources, because they know how to look up things safely on their phones, right? They know how to navigate around where they're not going to be discovered. They're a little more sly than my age is, So let's give them, everybody, that information and put it everywhere, and ask that other people, do that. I zoomed into a sociology class 2 days ago and talked about the intersection of domestic violence, pregnancy, and homicide in Louisiana. I zoomed into a class in New Orleans, and they have a really robust, group of, organizations down there doing this work, but they also have very high homicide rates. So, we need to get everybody on board, and we need to be creative and not just like silo and think, okay, it's just healthcare organizations or legal advocates. It's everybody. We're all like in this, right? So I don't want to take any more of your time away, Linda, but this was like excellent. I love having a conversation. It's so nice to see all these people who care about this issue like we all do. Thanks.
Yeah, I think one of the questions in the Google Doc was, what can community organizations do? I think that's what community organizations can do, right? Is to know that all of us together have a place in addressing this issue. And I think people shy away from it. It's uncomfortable. It's difficult. When we talk about barriers, I mean, folks, why do people not share this information? Because not just because they're afraid, because they're ashamed, because we have this whole culture in our society that has not uplifted this particular area. Janet, hi, good to see you. I see your hand up.
How are you? Yes, hi, I'm Dr. Janet Williams. I'm a midwife, just retired recently from clinical practice. But I wanted to say that when I was practicing, there were several problems I saw. We did very well with the screening process. But what I found is that a lot of the women that were referred to housing, they were referred outside of their area where they lived. So they had no support systems. They were basically told not to come back in the area because the perpetrator lived there. But that's where their families were, and that's where their health care was. So many of them went other places, but never really restarted prenatal care somewhere else. And most of them would come back, even though they were told not to, they would come back to deliver. And so the partner was like right there watching the family, and, many times showed up, even after months of absence, from the home, they kind of watched and knew that the person was going to deliver, and they would come to the hospital. The other thing is that when they were on the floor, I always tried to include the partner in helping care for the woman. That's how I would get them out the room. Like, I would make sure they knew where the water was and where the ice was and different things. And so during the whole visit, during labor and delivery, I'd say, could you go get me 2 blankets and a cup of ice? That gave me a few minutes to talk to her, with him out the room. So there, you have to just play all the different tricks that there are. But yeah, we try to, screen everyone and keep people safe, but there are flaws in the system as far as trying to get people reconnected with the healthcare once they leave the area.
Yeah, and I think it's that's why it's so important that we deal with it everywhere, right? So that you don't feel like it's all on me in this particular one situation, right? If everybody is having these conversations and everybody has this awareness, and you don't address it today, if it's throughout the system, then you're going to have confidence that somebody else is going to pick it up in another area, right? So that's why it's so important that we all work together to address it.
Right.
Yeah. This idea that, I have a whole, you can go on domesticshelters.com, and there's a couple of other that list all the myths. And one of the myths about DV is that, and SV, is that, these are weird perpetrators, or these evil people, and they're, but they're not. They're people, the guy next door, they're somebody's cousin, they're somebody's brother, they're somebody's son, right? And sometimes they have a persona that is very right. They may be they're forced to see an abuser that they know or they like, right? They can be very personable. Because, another myth, well, it's an anger management problem. Well, sometimes it is. I mean, we know that there are people that are angry, and for many reasons. We know that people have, had experiences in their own lives that have developed them into an angry person, and they are in fact angry everywhere, and they take it out in all of their relationships. But again, there are people that are not angry. They don't have an anger management problem, which is why we try to get, judges to understand sending him to anger management is not the deal, right? You have to send him to a program that is very specific for this issue. Understanding that the person is just about control in the relationship, but at work, they're not that way, right? They're very personable. They may be a law enforcement person. They may, which is why survivors don't want to be referred to law enforcement if their perpetrator. I can remember doing a presentation maybe 10 years ago, where the woman who I presented with was a survivor whose perpetrator was a cop. And, that blue line, nobody tells. And so her fear about reporting to law enforcement was, these are all his buddies. This isn't going to get anywhere. I call his buddy to the house, what's going to happen? And nothing happened. So, okay, lots of hands. Candace, hi, Candace.
Hi, Linda.
Did you want? Hi.
Yes. I wanted to get your thoughts or opinion about how anti-Black racism, structural anti-Black racism, white supremacy, sexism puts Black women and birthing people in particular, especially at a vulnerable position. You referenced how Black women, I think you said, are 3 times, if I'm not mistaken, as likely to be murdered during this perinatal period. And I'm just wondering what strategies have proven to be effective in preventing homicide, if any, and is it necessary to address that structural inequity based on race in order for there to be some sort of impact?
So yeah, Candace, the structural inequities are at the bottom of many of these issues, right? So we know that the whole policing system in our country was basically developed to get runaway slaves, right? I mean, that's the basis of policing in the US. So when we have a policing system that was developed from that, how do we expect that policing system to really address the needs that it in many situations has created? So unless we look at the structural systems in law enforcement and anti-Black racism and sexism, we are not going to make the kind of progress we need to make. And so absolutely, we need to, those are things that need to be addressed system-wide. I don't think we identified specific ways other than the only thing that we have that has addressed homicide in particular is having laws around gun ownership. So the problem with that is now the current Supreme Court that we have, is some of those laws may not continue to be upheld. But laws that restrict the ability for people to have guns as far as they go, because we all know that folks can get guns other ways, right? We know folks can get guns outside, going to a store and buying a gun. So if that was the only place that folks could get guns, then it would be more effective. But we have seen, if you talk about things that we have actually seen have made a difference, that one piece has been able to address homicide. So in states with stronger gun laws and stronger laws specifically about gun availability of weapons for people who have been convicted in sexual or domestic violence, that has decreased homicides. So that's one very, very small thing that we have evidence on. The other things I think have really not been addressed in the way they should be, because the society has not taken that as something that we need to address system-wide.
Right. And I think oftentimes there's a lot of victim blaming, especially when it comes to Black women. We're told to pick better partners. And that is not the solution, because there's so much happening structurally that puts us in these vulnerable positions as a community. It's really not fair to leave it up to that.
Victim blaming is very much more difficult with Black women, and when we look at the history, that for many years the definition of rape was that you had to be female and white in order to be raped. Right. So that in this country, this idea, this idea that, this whole idea that Black, the images around Black womanhood and Black manhood are stereotypical and contribute to the way people are treated when they disclose this information to someone. And then the fear, and it's a very real fear. I mean, if you are a Black woman and your perpetrator is a Black man, you want the pain to stop. You don't want him shot and killed, right? And so fear, if you report this in the legal system to police, is he going to get shot and killed? And so, victim blaming takes on a whole nother, there's a whole nother layer to it. Brianna, you had your hand up. I want to get to you before we close. We only have a minute.
just wanted to ask Linda, if you or Jamie or anyone else was familiar with these hand signals, and I was looking them up, like this, and I think this. I saw something online about ordering a drink at the bar and saying you want a shot with lime, and they'll have a cop come. Like, how can we raise awareness about this? Because I'm just now learning about it. How can we get, victims and survivors to know about it, providers, like teachers, everyone?
Yeah, I'm not familiar with that. I think it's a good thing to investigate, and Jamie talks about safety planning and danger and lethality assessments can decrease the risk for homicide. Absolutely. there is a danger assessment. It's online. You could also take the course to be certified to administer a danger assessment. But the two things that make it more likely to have lethality are strangulation and access to firearms. So those are the two main things. And when do we talk about access to firearms in healthcare? I mean, they're starting to talk about it. The pediatricians are starting to talk about it in pediatric offices, talking with parents about access to firearms. They're talking about it in a different way, talking about, accidental shooting for children for firearms. But it's really, yes, Candace, it's really, those are two things that, the whole danger assessment is something that you need the training to do. You can look it up online and get that form. But those are the two main things. And Black men are not inherently violent. It is the structural anti-Black racism and white supremacy that drive violence into our communities.
Okay, everyone, I'll be closing the breakout rooms, but if you have any other questions for Linda, please feel free to put them in the chat, and then we will make sure that Linda is able to see those. Thank you, everyone.
Oh, sorry.
Go ahead.
Hi, my name is Tiffany. I am an attorney.
I'm sorry, Tiffany, it's hard to hear.
Sorry, Tiffany, you're breaking up, so we're not able to hear you. Well, I'm not. I don't know if anyone else is.
No.
Can you hear me?
I think Tiffany said she's an attorney. Is that right?
All right, can you hear me now?
I think so, yeah.
Okay, sorry about that technology, right when you need it.
Yeah.
So sorry, I was saying, so yeah, as well, and this is something that has become extremely near and dear to my heart, with this social determinants of health and maternal health, which, I didn't see for a while. It took kind of my career, my life experience to see how it all connected, where I, for years, worked as an assistant attorney general for the state of New York, specializing in affordable housing.
Mm-hmm.
And didn't see, it's not really even something that we talked about, right? Like how that affected health. And for any demographic, it was just like, of course, in New York, you need more affordable housing. You need more affordable housing. And that's really that was like, the drum, more affordable, sustainable affordable housing, but not even really how that connected with everything else. And I am a mom too. I have a almost 2-year-old. He'll be 2 next month, actually. And he was really my experience with, or I guess they both were, but he was really what opened my eyes because he was born prematurely.
Mm-hmm. And
when he was born, I think I had allowed myself to be kind of in denial. I'm also a Black mom, so I think I was like, I can beat the system. I can work hard enough. I can do all these things. Not even thinking about weathering. I don't even think I knew about it. And it wasn't until he was born prematurely that it just rocked everything. Like it, and it really opened my eyes to this experience. And I was like, wait, people know about this. People know about these connections. People know about all these factors that go into it. And then me specializing in affordable housing, which is like a major one, it wasn't something that I felt like we talked about at all. Like it wasn't even something that we connected. And so I was just like once the veil was off, I was like, this is so obvious. Like, how are we not seeing these things? As I learned from my own personal experience with, perinatal mood disorders, being a NICU mom, and I had severe preeclampsia with health syndrome. So it's like all of that. So, I'm worried about my own health. And then, I'm learning more about just what the experience of being a Black attorney, a Black female attorney, with weathering and just trying to live up to, my colleagues who also often looked at me and not there's anything wrong with being a secretary, but I was an attorney just like them. And it was always like, yeah, but do you really know? I always felt like I was proving myself every second of every day. One win just got erased. So next day I could try to win again, and be like, I'm still good. I still deserve to be here. And so it was always that feeling. And that's life, right? That's just life. But when you're pregnant and you're going through that, you don't realize how these things seep into, your child and what is going on and that stress and all of that you're dealing with. And so I'm kind of just sharing, but I also am super interested in a medical, I don't know what's involved. I'm licensed in New York and New Jersey. So I'm super interested in being involved in whatever, I don't even want to narrow it down because this is just really something that is like just near and dear because I've lived it. I've lived so many of these aspects in ways where it was so siloed that it was like, oh, but this is just that. And no, that's just this. It's easy to kind of just compartmentalize things and not realize, no, this is all to, one holistic situation. And I hadn't looked at it like that. I mean, even with my first child, I had postpartum depression. I had a Black OB, and I chose my Black OB in New York City because I like instinctively thought like, oh, she'd looked out for me. And so I was also 35 when I had her, so I was like, AMA. So I'm like, she'll look out for me, right? She'll make sure I'm okay. And I guess, to some extent, but when I presented with symptoms of postpartum depression and talked to her about it, she just said, well, you're healed physically, just go find a therapist. Like it wasn't her problem. She couldn't be bothered with it. And,
Right.
so.
So Tiffany, I had a similar experience with a physician as well, who kind of dismissed me when I asked questions. And she said, oh, she made me feel stupid with the medical student and said, oh, postpartum mom, she doesn't know what she's talking about. And I also, my first daughter was not quite premature, but she was in the NICU for a while. And thinking back, I'm like, you know what? Thank goodness I had stable housing, health insurance, right? Because it was like probably the lowest time of my life. And thank goodness she was okay. But parents going through something traumatic like that, I had a very traumatic birth. And then my daughter ended up in the NICU having such a traumatic time. And if all those other factors of my life weren't in place, I don't know how I would have fared. So imagining moms who don't have those opportunities and those advantages, they're dealing with deplorable housing conditions. They're dealing with domestic violence on a regular basis, like, Linda mentioned. They're dealing with income insecurity. So, and interestingly enough, in my organization, I started doing research on medical legal partnerships back in 2017, right before the pandemic. It opened my eyes. I'm like, all these states are doing so much. Nebraska has a medical legal partnership in every hospital system that they have. But we are slow, and it's interesting. I showed there's a video, not particularly to maternal child health, but a general video on the Nebraska model of medical legal partnerships. I actually showed that video during another presentation that I gave. This was way in the beginning when we were just getting involved in medical legal partnerships. And somebody in the audience after the video got up and looked around and said, are you kidding me? We're behind Nebraska. No offense to anybody from Nebraska, but being New Jersey in the Northeast, we're behind these other states in this type of work. So again, and unfortunately, we've all worked in silos, right? It's changing your mind frame, changing how we think about providing care to patients and looking at it as, okay, holistically, what does this individual need? It takes a village. We always say it takes a village to raise a child. It takes a village to assist patients, especially low-income patients who are living under the poverty level. And we're so in terms of medical legal partnerships, yes, there should be an investment by the state really to make this universal through whatever channels. And, the grants when they come out, and pretty much every grant that I see now talk about social determinants of health in some capacity. So it's nice to see that there's more of an acknowledgement about addressing social determinants. There's a recognition that it's important to address. So when we see that, we're like, okay, there's an opportunity to really bring in the legal piece that's necessary.
Mm-hmm.
And really the legal piece is probably necessary in all populations that we serve.
Right.
We're talking about the low income population and specifically maternal and child health. Mm-hmm. So as you saw from the DC video, they're embedded into the hospital. There's an OBGYN that is strongly supporting and advocating for this work. And we need that to happen here and really bring this to the medical community as well.
Yeah. I noticed in that video too that there was partnership with, for example, Mama Toto Village. So I don't know that perhaps they, send some of their clients that give birth at that hospital. They ensure that they know about the medical legal partnership. And so I wonder in New Jersey, first of all, I feel like anybody who is here now can become a champion of this process, right? That's how I even came to know of it. I joined a presentation that Erika did, I don't know, earlier this year, maybe. And I was like, why is this not, something that is being discussed more and being embedded into organizations, even something like, again, writing a piece of the budget for a grant into so that the medical legal partnership can have a piece of that. I feel like that's just a simple add and ask and something to do to really move the needle for sustainable changes, right? Because even if someone, they give birth healthily, et cetera, if they have legal issues, if they have issues on any level legally, there's going to be problems. But I want to save space for others to provide some perspective and share some of their questions, et cetera. So anyone who has, I saw Linda had her microphone open for a moment. So I want to make sure that you can ask your question.
Sure, thank you. So I'm a nurse with a master's in public health by training, and I run a health and wellness program at a homeless shelter for families. So it's Homefront in Mercer County, New Jersey. The primary mission of Homefront is to provide housing. And so I'm just a small piece on what we call our family campus, which is the actual shelter. And I think my question is, how do we start a partnership? I mean, I see every day, every single one of our clients have like so many social determinants of poor social determinants of health, and are homeless, and have how do we start a partnership when you're a small nonprofit?
So it starts with a conversation. Okay. It starts with leadership from the organization or anybody else from the organization reaching out and saying, this is what we're interested in, how can we work together? And that's happened. What they do is look for maybe opportunities through funding, within the organization, or if there's a grant that you're applying for, including us in the grant application. So that's how these partnerships that have developed. And providers are reaching out to us and saying, we need this, we're going to look for money. And it doesn't, starting off, we could start off as a pilot. It doesn't take too much, right, in the scheme of things, to start off as a pilot and then growing it and then showing the value of what we're doing. So honestly, our partnership can start off with $50,000, $75,000. We start off with maybe, depending on what it is, it could be like 20 patients, consumers. We address all their needs. Whatever legal issues that they have. And, we can start small, 50, 75, 100,000, whatever it is, and then grow it. And that's how some of our partnerships have grown, because there's a recognition that there's more of a need, and then they ask for additional funds, or we go to the state, we advocate, we need more funds for this. But I think the key is to start somewhere, right? We need to start somewhere, and because that's what New Jersey wants to see. So we've met with New Jersey leadership, state leadership, about all of this. And, yes, they're interested in what other states are doing, but they want to know how New Jersey's going to fare. They want to know, how is this going to affect New Jersey? Bring me statistics from New Jersey. And we did an outcome study with one of our other medical legal partnerships, with another, with a mental health population. And we did have some data, but it takes time to gather that data. You need longitudinal data to show, okay, what are the health outcomes? So I think the key is to start, is instead of, we keep talking about it, is we need to start somewhere, even on a small scale, and then build it up. Oh, Isabel, you're on mute.
Can you hear me now?
Yes.
Yeah. Hi, good morning, everyone. This is a very interesting topic, and I wanted to add to all these stories. I came here to Women Rising. I'm Isabel from Women Rising, and I'm working as a community health worker, right? But I went to school to become a paralegal. I'm a paralegal, like, the school. So since I'm working here, I love the job, by the way. We have the domestic violence department here, and there's a lot of clients coming to me from domestic violence, right? And I see this legal aspect, it's very important. And I'm willing to start, I'm willing to do anything to start this, because right now, when I have these clients, I have 2 clients specifically right now, where they were the victims, right? And then the abuser put a counterclaim, and they become the abusers. And now the court doesn't want to listen to them, because the legal services that we have around, they do not represent the plaintiff. No, the defendant.
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 Oh, okay.
They don't represent the defendant. And I've been trying, I'm knocking at every door, I'm looking at every resource, because this is not right. And we have, so Women Rising, we have counseling also, and my coworker who is psychologist, she has the reports from these clients who are the victims, right? So we really need to work on this. This is very important, because no one wants to represent them. Now they are like abusers, and they're going to have criminal charges. And okay, fine. But here's the thing. We have women by themselves with babies. They don't have money to buy clothes. They don't have money to pay a rent. They are in those houses, the abusers' houses. They live in those abusers' houses because they can't get out. How are they gonna go out to look for a job if they have a baby at home? And lawyers are telling them, oh, but why you don't work? Like, hello? They don't understand. When we as a woman understand that we have a baby. I have 3 on my own. And not a baby. My kids are old. But yeah, so we have, when we have a baby has to sleep. Baby has time to sleep. I cannot just look for a job when I have a 2-year-old that it's not ready to go to a preschool. And if I want to live in a daycare, then I'm going to have to pay like $200 for a week. So how, and how you ask this woman for this much? No, that's unfair.
Isabel, what county do you work in? What county?
Hudson County.
Okay. So my organization, we represent either side, both plaintiff and defendant. I worked at Legal Services, and I know the priority is to represent plaintiffs. And I did that for many, many years, but our organization, right. So because a defendant could be a victim too, right? If the abuser is the one filing, or their counterclaims, right? Their cross complaints filed. So yes, again, we're willing to talk about this, and again, we can start small and scale up if there's a need. I'm hearing that there are needs, and we know this. We know this.
Yeah. I think what struck me about Isabel's comment too is that having a representation that understands the complexities of the maternal and child health continuum is really, really crucial and critical for really receiving the assistance that you need. Because early in your presentation, Erika, you said that you had 800 people, but 900 claims or something like that. Whichever words you use. And so you can see even with this example that Isabel gave, there's a lot of different nuances here, right? And so someone who understands this is going to be able to really pick this out and really assist the family, the individual with what it is that they need and target that. And so that's what really struck me about that comment.
And I think also is that if we're going to obviously target this population, we're training the providers about legal issues, but it's also very important on the other side is for the clinicians to train us, right, about what the maternal and child health needs are, so we have a better understanding. So it's a two-way street. Again, like I said, it's a partnership. Yeah.
I wanted to ask something to Erika. Okay. Now that we hear, Erika, please don't take it as a disrespect, but so like if there's any way to help my clients at this point, there's any way to they can represent themselves or.
So right now, I mean, we have an office in North Jersey that does assist individuals, but our funding is very limited. And we only assist individuals with disabilities, chronic health and conditions, or the frail elderly right now.
Okay.
So we're going to build a partnership specifically for this population, then absolutely, then we can assist, these moms. Now, if they fall into another group that we can assist, I mean, you can call our office and see. We can talk, you can send me an email. I know Cecile is going to send out my information. Karina or Cecile are going to send out my information with my email. You can send me an email and I can see if we can help those specific women with the funding that we currently have now. Again, it's limited for Hudson right now, but you can send me an email. Okay,
I appreciate it. Thank you so much.
You're welcome.
There's also another legal services. This is a conversation that comes up often because I bring it up a lot. But and you may know this one, Erika, the Latin American Legal Defense and Education Fund, if your families fall into that space. That is also another resource that may be more targeted for your needs at the moment.
Which one? I'm sorry, which one was that one? Legal Latin American?
It's called the Latin American Legal Defense and Education Fund.
Okay, thank you. I'll search that.
Okay, any other comments, questions, ideas?
I have a question. So when it comes to creating partnerships and how do I say this? For specific communities of color, I represent Black people because I am a Black woman. But with creating a partnership with a legal system that doesn't typically include them in positive outcomes, how do we have these kind of conversations to where it's received in a positive way, so that they can see the partnership as something that's beneficial as opposed to detrimental? Because I always think about the situation of child protection coming in as criminalizing Black families as opposed to coming to provide resources, which is what they're also supposed to do, right? So it makes I've seen it makes more Black families resistant to asking for help or support. So same thing when it comes to the legal system. If they haven't been treated fairly, or if they've been, I guess, having more punitive or detrimental circumstances when dealing with the legal system, how can we then say this is a partnership that we want to actually build it's good. You know what I mean? Like, how do we open those kind of conversations up?
So I think trust is very important. And I think that's where we really depend on our partner to engage with moms and families. And we're not there alone. We're there as a partnership, right? We're engaging with them as with the partner to really talk about these issues and say, you know what, and everything they tell us is confidential, right? Unless they sign a consent waiver, I can't even tell you about their issue, even as a partner.
Right.
So all that information is confidential. But, they have to understand that, certain aspects, if we do see, we have to be also upfront with them, right? About child abuse and neglect. We have to be upfront with them. I litigate child abuse and neglect cases for 3 years in New York. So I understand that dynamic. But what I also understand is that many families, the reason that they're in the child welfare system is because of housing and income issues. I had a family that I represented here when at the Law Project a few years ago, that they were separated because of lack of housing. And, we were able to, she was being, the mom was being evicted, all these issues. And, also knowing what the resources are, right? There was a specific voucher that we were able to get her, family unification voucher. So I think, again, to answer your question, I think it's a collaboration and really engaging with them as the partner. And it takes time to build trust, but you also have to be very honest with them.
Yeah.
It's honesty is key. And I think that's also how you build trust. But they also have to understand that what they tell us is confidential to a certain degree, because if we determine as attorneys that either a crime is being committed or a future crime is being committed, that's something that we have an ethical obligation to report. So I do think that, and obviously, the welfare of a child is very important, and we want to make sure about that. But again, and then they decide, we're upfront, we're honest, and then they have to determine if it's best for them to engage with us, like just with any client that we serve.
Yeah. So I totally understand. I don't want to monopolize it, but just to kind of go a little deeper into that. What I'm seeing when we're having these kind of conversations of introducing them to other social services that can escalate support, but also escalate whatever lived issues they have going on. If we're not partnering with an organization that understands cultural barriers or cultural needs of said family, something that you may determine as oh, this falls under neglect or this falls under abuse because you're not aware of their culture, not you as a person, but in general.
Right.
This again can re-traumatize them, and then it also can taint us as the community partner. It can taint the relationship that they have with us. So I know for me, when I'm thinking about partnering with other organizations that are outside of what my company does, I think about that. How does the community already have a perception of you as an organization, or, what your organization does in terms of, legal or healthcare or social service, whatever, and then really determine is there a way for us to build, or is your company or your organization receptive to hearing the people out before creating those traumatic events? Does that make sense?
Absolutely. And I absolutely respect that. And I totally agree with it. So we represent people with severe mental illness and disabilities. So individuals working at our organization already have to have that sensitivity, and understanding and empathy and sympathy, and a lot of patience. So I do think it takes that. So we're already, I think, well-versed in that area, and in terms of cultural competence as well. So, but I think we would also look to the partner to help us, right, to educate us on what the needs are, and the cultural differences and things like that. I think that's very important. I think I don't profess to know everything about, I wouldn't. So that's something that we would rely on of our partner to explain and to really, again, work with us when we're helping patients. It's not, oh, here's an attorney to help you. It's
Right.
Jay, I'm going to have to work with you so we can talk to this patient together. Let's talk to them together. That's really how it needs to be.
Mhm. Yeah, this is a great question and a very salient point for this conversation. I think that, thinking about and moving into measures that are not punitive, but that help to build families up is also very critical in any partnership or in any situation where we're saying that we're providing services that are around social determinants, right? There's a lot of education that has to happen on all sides, the community partners, those being served, all of them. So I think that this is a very important and salient point. I have been taking some notes during our conversation, so I'll be doing the share out because I didn't give anybody the opportunity to take the notes. I should have, but we are going to close in 5 seconds and I'll see you in the larger room. Fantastic. Welcome back, everyone. I hope you had a great conversation and connection in your group. I know we had a fantastic conversation ourselves. So we are going to move into just doing a share out for what we discussed. So I have the first group on intimate partner violence to share first. And yes, absolutely. So whoever's going to share out, please feel free to jump in there.
Hello guys. I was back and forth, multitasking, but I was able to jump in on the last part of, and I just want to say it was affirming as a survivor and as someone who's had to navigate the DV system. I saw a lot of information being raised about, the onus on the victim and on the survivor. And if I move, I have to uproot my whole life, go to a different county. And in my case, some of the legal issues earlier from the earlier session plays out when the restraining order was never actually served. So I have no final restraining order. I have an indefinite TRO. And you have to, you have to keep it up and you have to keep the safety going, even though you did everything right. And so I just wanted to say that was affirming to see that people are noticing it. And I would love to see us raise more awareness and see that systematic change. And that, how can I put it, that lovely question of why and the nosiness. And no, it is re-traumatizing for me to explain why I stayed. And every time I almost feel like I'm defending myself every single time I step into a space to receive services and having to rehash it, even though the service supports aren't there. So that was very affirming, while at the same time knowing other people are fighting to change some of this. So thank you guys.
Thank you so much, Ms. Foster. Anything else from that group? Anything else to share out from that group?
Good morning. My name is Chantel. I was in the intimate partner violence group as well. And we talked about also like access to firearms and strangulation as like the leading causes of like homicide, and just like how we can approach gun control and also mitigate like the police killing the Black man. Because like in my case, like when I was being abused, like my abuser was bipolar. So like there was really no services available for like when he was having like those episodes and stuff. So like for my safety, I had to get out of that relationship. But it kind of like sucks as Black people, like we don't have like those resources to address like mental health, especially in Black men.
Thank you, Ms. Fletcher. So if there isn't any other for that particular group, we can have share out for the Medical Legal Partnership Group. So Jaye, you can start off.
Sure. So our group, we talked about the medical legal partnerships, what it looks like to create those partnerships, what's necessary for others to build relationships and remove us from those silos. One of the first things that stood out in our conversations was one person shared out about her experience as someone who is well resourced and has the financial means, but still facing a lot of the same barriers that we typically hear are only associated with poverty or different areas of limitation, and how that also was exacerbated by race and ethnicity, right? So understanding that person's personal experience as an individual person of color versus a system that doesn't always include them, regardless of their educational background, their income, they were still adversely affected. So with developing relationships, and and this person also is an attorney. So their professional background as well as their personal background seem to have a lot of intersections. And I wrote down, it changed their concept of who is impacted by these issues as opposed to what can determine the reasons that people are impacted by these issues. We also talked about how there are other states that may not have the perception of having more resources than we do in the Northeast, particularly the Nebraska model of medical legal partnership and how that changes the mindset of how care is delivered. And we typically think we're here in the Northeast, this is the land of milk and honey. However, we're so limited in the way that we're able to see what resources are available or what care can be provided, because there are a lot of people that still work in silos, right? So we learned that having conversations like this actually opens up what resources are available and talks about what type of partnerships really need to be developed. And then lastly, we discussed more about having a reciprocated conversation with each partner. So I wrote down creating an MOU to understand how to create a trusted relationship in a legal system versus a community partner system, and knowing that those relationships take time to build on both sides, right? But we're both able to teach and learn from one another in order to get to the same goal. Did I miss anything?
That was a great summary. Thank you so much, Jaye. I think that was a lot of what I had. I think I'll also throw in there that a question was asked about how do you start a partnership if you're a small nonprofit? And so New Jersey is sort of wide open for the possibilities. While there has been conversations with state government, it's still in process of seeing how these things can be integrated. And so if you do have a small nonprofit, you can start off with a pilot where you write it into a grant application, for example, where you can do a sample size, and this can really help to build the data around how this is supportive in New Jersey. And the other thing is that, some of the actions that we can take is to really champion medical legal partnerships in the state. So now that you know about it, continuing to learn more, but also to share with your systems and people that who can make an impact and have influence on this, to bring this into spaces. And the same thing with intimate partner violence. If this is not something that the systems that you work with are thinking of screening or talking about in the impact that it has on maternal mortality and maternal and child health, then it's something that you can champion in your respective organizations, because we want to see more social determinant of health solutions embedded into these systems and into the mindset of providers and into the mindset of those who are doing the work in New Jersey. And so this is a huge piece of, or cause or purpose of this conversation. So I don't want to overtalk because Corinne is doing the time check. So we are now at the point where we are going to take a break. Get some woosah in there, get some relaxation. We had some heavy topics this morning, and then we will come back. Corinne, I'll have you give us the times and all of that. So.
Yeah, everyone. So we'll come back in 10 minutes. So at 11:05, we'll come back and regroup, and then we'll get started on our next presentation.
All right.
Yeah. Thank you, everyone.
All right, I heard the music stop and I was like, okay, it's time. Welcome back, everyone. We'll just give you all a second to it'd be great to see your lovely faces. Turn on the camera if you desire, and get started in part 2, or the second half of our conversation and our presentations, I should say. And we are going to start out with Jaye Wilson, who is going to be discussing another part of social determinants of health, which is transportation needs. This is something that, again, came up in the research that we did, that NJBEFA did. And so just to introduce Jaye, Jatisha Jade Madden Wilson is a Black woman, mom, social entrepreneur, social impact speaker, maternal health advocate, published author, and self-sufficiency coach. Jaye has created big strides in advocacy for women of color, most notably with the First Lady and Governor of New Jersey as a public speaker and maternal health advocate for Nurture New Jersey with the Black maternal health crisis. In her professional career as a community health nurse, she provided clinical care and moved into clinical operations as the nursing operational manager for Kaylin Lord Community Health Center, a federally qualified health center that specializes in providing care for the LGBTQ+ community. Jaye received her first opportunity in advocacy while at Kaylin Lord and began lobbying in Washington, D.C., Albany, New York, and Trenton, New Jersey as a community advocate for the LGBTQ+ community. While in these positions, she saw the importance of how community advocacy and engagement created better physical, emotional, and mental health outcomes for its people. After 10+ years at Kaylin Lord, Jaye went through several transitions, both personally and professionally, which sparked the idea of creating a community of support that changed the narrative of motherhood, sisterhood, and womanhood. Starting as a small community, a small mommy meetup group, Melinated Moms quickly grew into a health equity focused women empowerment organization that changed the way community engagement related to maternal health. As her organization has grown, she has incorporated the additional titles of published author, and she was recently appointed by the Governor of New Jersey as a special state officer for the New Jersey Maternal Health Quality Collaborative. Welcome, Jaye. Looking forward to your presentation.
Thank you. Every time I hear those things, I'm like, dang, that's me. It's weird. But I appreciate it. Thank you so much. I'm going to share my screen. Present. Small. All right. So I'm like incredibly visual, and as you can probably tell, I like a lot of color. So I'm sorry, and you're welcome at the same time. But again, thank you so much, Cecile and NJBEFA for this great opportunity. My name is Jaye Wilson. I'm the founding president and CEO of Melinated Moms. We have been in operation for the last 6 years, really learning how to create new strategies around changing the narrative of maternal health support through all of these different measures, right? In the work that we've been able to do, we have learned more about what barriers are existing in our communities by just asking those simple questions, like, what is it that you need? And, you know, as we heard earlier today around the social determinants of health being a huge contributing factor to the way that people are able to be well, have support, and interact with one another, transportation has almost always come up. So in my presentation, I'm going to discuss, you know, how transportation continues to be a barrier, as well as how melanated moms and NJBEFA have contributed to the way that we have, you know, created new strategies to break those barriers. So for context, I'm going to be discussing what the problem is versus what the solution is, and how transportation barriers impact health outcomes. I'm going to then discuss partnerships and how they create the progress that we need. So relationship building creates the impact on breaking those barriers. Then we're going to go into how people find resources and become resources. So we're going to, if you ever gone to any of my trainings, you know, I love an acronym. So we're going to talk about how you scan your options. And then last but not least, it's just how you can connect with melanated moms. I love to make sure that we keep those communication lines open. And I'm always grateful for any ways that we are able to create new community partnerships. Okay, all right. So let's talk, you know, let's really talk about how we can understand what barriers look like and how it also is impacted by transportation, right? So thinking of these 4 barriers: financial, personal, the impact of COVID, and then labeling and judgment, as a way that families and individuals look at how they're able to access transportation and get to where they need to go. So starting with financial, understanding how financial burden versus your financial capacity can really impact the way that you're able to take care of yourself and your family, right? If I don't have the money to get there, I'm probably not going to go, right? If you're having issues with employment stability, your hours are changing, you're not able to perform due to illness, you know, calling out, having all of those other issues, excuse me, our children being sick, all of those things create barriers on one's finances. Now, personally, understanding how you may want to go into not having to rely on public transportation or ride share, but, you know, how can I obtain a car? How can I make sure that I'm able to afford something like that? We have to look at, you know, those same financial barriers. We have to look at credit. We also have to look at how inventory has changed in terms of what cars are available, and how the prices of cars, gas, maintenance, as well as availability have completely changed, especially since COVID, right? So those personal barriers can also create, you know, a feeling of burden. You know, I don't want to ask someone to help me, you know, if I don't have the means to do so, you know, and sometimes we will impose those barriers on ourselves of being silent, you know, because we don't want to, you know, create a different perception of us not being able to be self-sufficient. Third is the impact of COVID. So as we saw, COVID blew open so many doors around what inequity as well as what accountability really looks like when being faced with a health crisis, right? The pandemic showed us that regardless of income, regardless of preparation, regardless of where you live or how you live, everybody was impacted by that, right? So COVID also changed the way that we're able to go into seeking any type of supportive services, such as food stamps, or even going to the motor vehicle, right? I don't know if y'all remember, but anytime you try to walk into the motor vehicle center, if you did not have an appointment, you will be turned around, right? The appointment times, the places that you needed to go became very limited. The impact of COVID on the staffing, it also changed the way that people were able to obtain licenses or remove suspensions, or even go for a permit, right? So COVID completely changed the way that people are able to break those personal and financial barriers. And then last but absolutely not least is the labeling and the judgment that comes from being in a healthcare system that typically does not and has not shown support to Black and Brown communities specifically, but as a whole, understanding that if a patient, and I'm speaking from the space of also having a nursing background, if a patient is non-compliant or labeled as non-compliant, it's usually coming from them not showing up to appointments, them not obtaining the medication or following or adhering to the recommendations of their clinical provider. And while we understand how social determinants of health is a contributing factor to poor or morbidity outcomes, we're not seeing any changes in the way that care is being delivered because of that. So for example, if we have a mom who's in a domestic violence situation or a birthing person who's in a domestic violence situation, and they come into their medical provider's office late, the first person they'll see is that front desk staff. That front desk staff may see this person disheveled, may see this person however they present. But instead of asking, do you need support? Do you need help? Is there anything I can do? They'll say, you're late, we're not going to see you, right? So if we're understanding how that can change the label of them being compliant or not, them being able to access care, them being able to participate in the type of care that they need, we need to shift the way that we ask for the solutions to these problems that can, again, be impacted all through transportation. So for us at Melinated Moms, the biggest thing that we always like to highlight is understanding the impact of the 6 dimensions of health and wellness and how that also can be seen through transportation barriers, okay? So we discuss what physical health barriers, we discuss how physical health barriers can be impacted by understanding, like I said, non-compliance, morbidity, and mortality. If a person is not physically well and they are not able to articulate that, or they're not able to get to a place where they can be supported, their health declines, right? Mental health barriers. So understanding how mental health fatigue, depression, anxiety, and then lack of support, it also impacts people's decision-making skills, right? So having the ability to really comprehend what they need or where they need to start in order to get the support. That's a huge barrier, right? So if I am exhausted in my mind, if I'm so overwhelmed with responsibilities, if I'm physically not feeling well, if all of these other things are weighing heavy on me, sometimes you feel stuck and you do nothing, right? So not being able to connect to a provider, or not being able to get to your mental health provider, that again can create a barrier. Social health barriers. So understanding how isolation also can exacerbate these same feelings, not knowing how to ask people, not feeling as if you're a barrier, or a burden to them. Those moments can also isolate that person to feel that they're the only one that's going through it, right? Not being able to seek out a friend or a companion or a family member or a community partner to help them to process those thoughts or help them to navigate to a different space, again, serves as a barrier. Understanding how occupational health barriers also contribute to what we've been discussing, right? So being able to make ends meet, it can definitely be very daunting. But if you're unable to secure reliable transportation to get there, or if you're depending on the funds from that job or that your career path in order to support yourself or your family, it can, again, serve as a barrier. I would love to get to work, but I don't have any money to get to work. What comes first, right? Environmental barriers. So, as we heard earlier today, understanding if a person lives in a safe environment, Are you in a household where you have the support that you need? Is it an IPV situation, right? Is your neighborhood a safe place for you to walk, or a safe place for you to even access public transportation? Do you live in a place where ride sharing may not actually go? You know, we have to really consider how much of these things really impact the way that people access transportation. And then last but not least is spiritual health barriers, right? So feeling grounded in a higher power and being connected to a church, synagogue, temple, mosque, or other religious institution creates a lot of balance for people. So there are some people who may not want to go to therapy, and that's totally fine. That is their decision, but they may seek the type of support that they need through a religious or spiritual leader. But again, if they can't get there, they don't feel whole. And all of these things really do impact the way that transportation can change what they have access to, what they think is available to them, and then also the decisions that they have to make thus after. One thing that's important to us is really to talk about how partnerships have helped melanated moms, as well as the other organizations that we've worked with, break those barriers down, right? So our relationship with Lyft has completely changed the way that we're able to provide support. And it's also given us more opportunities to look at not just the one part of transportation, which is obviously going from point A to point B, as the barrier. We're also looking at policy. We're looking at how data shows or reflects the way that these impacts are recorded. We're looking at not just the quantitative data, we're looking at not just the quantitative data, but also the qualitative data. So hearing the testimonies of our moms and our birthing people who have been impacted by the work that we've done with Lyft is super important. Again, for us, utilizing our partnerships with Black Ladies in Public Health, we've been able to create more impact reports. We've been able to look at different databases, such as the ALICE report, to really help us to create better strategies around transportation as a barrier. We've also been able to lead the Coalition of Change for New Jersey, where we've comprised 26 organizational leaders throughout the state of New Jersey that represent all 21 counties, as well as our regional partners in New York and Philadelphia, to really get a huge grasp of what kind of resources are available, where families are going to access them, how they're actually getting there, but then also how do we make sure that we create equity with revealing all of this data and learning from the communities who are impacted by it, right? Additionally, working with Earth, the Amaka consulting firm as an evaluator, Once Upon a Preemie, the March of Dimes, and Nurturely. All of these relationships have really helped us to strategize around creating equity and looking at, again, transportation and how it impacts those 6 dimensions of health and wellness. So, sorry. All right, here we go. So one of the things I'm really excited about to share is the way that we've been able to break those barriers by looking at how impact has changed access, availability, and accountability measures. So I'm going to share some data that was shared from our contact with Lyft, and really understanding how impactful it really is on our economy, as well as on the overall health of moms and women and families, right? So let me see. It said it's going to be interactive. Open. Can we open? Nope. Okay, I'm going to try. Okay, maybe I just have to click it. Okay. All right. So starting with who is driving, literally, who is driving the Lyft, right? Who is providing the Lyft? So drivers need the flexibility that independent contracting provides. So 91% of the people who are driving Lyft rideshare, they work or they are students, in addition to engaging in this app-based work. So what that means is it's creating more opportunity for people, regardless of their income background or their personal structure, to have a means of transportation for someone else, but also create more economic opportunity for them and their families, right? 71% have a job or are looking for a routinely provided care for family, for their families, and a job outside of just working for Lyft. So understanding how impactful that is with creating flexibility for families, because all families are unique, right? We're not structured in all the same way. And there are times where your bills will be more than what you bring in. So having the ability to utilize Lyft and creating your own schedule, creating more opportunities, looking at the peak hours, that's really helped to impact our economic development of our partnership with Lyft, but also the impact on the families that they're supporting. One of the things that, I will share all of these reports. They are going to be emailed after, so you can read them all on your leisure and share them with your networks. But one of the things that I really wanted to make sure that I covered is how Lyft impacts non-emergency medical transportation. When we think about moms and families getting back and forth to the doctor, that's absolutely important. But if we're also looking and talking about social determinants of health, we know that it's more than just a doctor's visit that really impact the way that people are able to take care of themselves and their family. So in their report, 9 out of the 10 top health systems use Lyft, and in 19 states plus in DC, they have incorporated Lyft as a partner of their Medicaid NEMT programs. So what does that mean? That really means, one, it shifted the cost away from that parent who may be limited economically, regardless if it's poverty or I just don't have it today, right? And they put it into a space where their health insurance, their public health insurance can help offset that as a burden, right? So knowing that you can utilize that Lyft so that you can go to the grocery store if you live in a maternal health, if you live in a food desert, right? Same thing for having to go to a doctor's appointment or a specialist. If you're living in an area, where that resource is not accessible to you, or, if it's an emergency or, a non-emergency, Lyft has been able to break those barriers. They've also been able to shift the way that policy recognizes how Lyft is also continuing to break those barriers. So it is estimated that over $6 billion, and that's with a B, $6 billion is spent annually on a federally mandated benefit. And we know that if Medicaid is able to contribute to getting people to where they need to go, then over time, we actually see how healthcare bills and then the use of the emergency room for primary care or other non-emergent services actually go down, right? So if we're able to shift those costs into areas that's way more effective and more impactful, we'll see these huge changes. Okay. So as I was saying, it does improve our patient outcomes. It decreases their overall system costs, and as well, it changes the way that wait times and no-shows actually impact the way that people are labeled as non-compliant or not a part of their healthcare. And when we talk about maternal health and the way that our state has improved significantly, we do have to remember New Jersey is one of those very unique states where people will cross counties to go to receive resources. However, we're not getting the full story of what that means, right? So Lyft being able to break that barrier of transportation, they will help moms or families go across a county to access this care, access this service. But what we need to do and what we need to continue to advocate for is being able to have more accountability measures that actually do track. If a family member, if an individual lives in Hudson County, but they have to go all the way to Passaic County to get service, both counties need to be counted in that, right? Not just where the service is being utilized, but also where a person is traveling from, like where they actually reside, to identify that might be a desert for that particular resource, you know? And again, I'm so excited and so proud that LIFT has really been strategizing around how to make sure policies are including transportation and shifting how the social determinants of health impact people. Okay, go back. Here we go. All right, so I just wanted to share some statistics around how we were able to impact some of our moms. So this was a snapshot of 1 year. So we were able to provide transportation through our partnership with Lyft for over 100 families spanning across New Jersey, as well as 5 additional states. 37% of those that used our service, they used it on a reoccurring basis. 21% before our program, they had never used Lyft before. So we were able to introduce them to this as a service, and then they were able to come back and reutilize it, right? 95% of the people who, utilized the Need a Lyft program through Lyft and Melinated Moms, they are our free subscribers. And 92% of them are moms. 8% of the additional people are guardians, healthy women, healthy family, community health workers, as well as dads and other people who are contributing to that family's needs. The 3 largest areas of barriers that we saw that were broken was transportation to and from doctor's appointments, transportation to and from work, and again, transportation to and from grocery stores. So I wanted to just share a few of our partnered testimonials from some of our moms. I did not have to rely on anyone to get to and from the NICU after the delivery of my twin babies. So this mom, she gave birth to her children early. Both of the children were admitted into the NICU. One baby was actually able to go home before the other. And this was actually during the pandemic. This mom had no reliable transportation, and she felt like it was a burden to ask certain family members for that support. And she was actually getting on the bus with a vertical C-section suture to go back and forth to the hospital to see her baby. So for us to be able to provide her with transportation so that she's able to heal, so she's also not exposing herself or her very frail children to communicable disease. And we were able to help her to save funds for herself so that she was able to personally obtain her own vehicle, and she actually ended up becoming a Lyft driver herself. So just that one snapshot helped us to really understand, like, this is way bigger than just saying you need to get to and from a place, right? That mom was able to really take that amount of time to pour into her children and pour into herself so that she was able to make more conscious decisions on how to move forward, right? So when we're thinking about this, we have to remember it's not just she needs to get here, she needs to get there. It's understanding that there are so many other dynamics that build into what transportation can really impact for a family, okay? All right, so I said, I love an acronym. So whenever I'm telling anyone about breaking a barrier, but specifically in the space of transportation, I want you to scan your options, okay? So S stands for speak up, right? So how do you ask for what you need when you encounter a barrier? Asking family and friends, that's fine, right? But what other resources do you know of, and how can you ask, right? How can you ask someone to find a resource that you need? As we just learned, Medicaid is providing this as an added benefit. How can they find out about it? You don't know until you know, right? C is community partners. So what are the local supportive partners who can help solve this problem, right? So looking at other grassroots organizations such as ours that have created partnerships and have created different networks within our own communities to really help solve this issue. That's been able to strategize a whole new way of utilizing the community to solve the problems of the community. A is access and availability. So what programs and services can you access and how soon are they available to break the barrier for you, right? So understanding what you have access to if you are a Medicaid recipient, if you're not, if you receive private health insurance, do they have this as an added benefit? Ask, right? And then understanding what is available to you and how do you utilize it. That's how we were able to see the impact of access and availability. And then last but definitely not least is that network of support. So what networks of support are available outside of your community, right? So looking at larger organizations like Planned Parenthood, March of Dimes, national organizations that do provide different resources for families based on their unique circumstances or situations. They also may have these same program access, right? So for us with Melinated Moms, when we began our partnership with Lyft, we were one of, I think, 35 other organizations throughout the state that was able to impact transportation for other families based on, who we uniquely served. For us, unfortunately, our program has ended in terms of being able to give free rides to our moms. But what it has actually expanded to is we are now a partner with Lyft on the policy side. So we're learning more how to be impactful on that macro level. And last but not least, you want to learn more about the programs and services and the impact that Melinated Moms continues to do, or if you would like to be a partner with us, please connect with me. So you can always scan the QR code. You can send me an email to contact us at melinatedmoms.com, and you can follow us on all of those social media streams. I'm definitely open to any questions anyone has, but I appreciate your time for listening, and I hope that this was just as impactful as it was to create.
Fantastic. Thank you so much, Jay. We are going to hold the questions until or perhaps after, just so that we can slide on through the presentation.
Sorry about that.
Presentation. No. Thank you. I really appreciate this ability to see the intersections of maternal and child health and maternal mortality concerns and transportation, because again, something that we know is an issue, but thinking about what the solution to breaking down that barrier is, one of the solutions anyway, has been very impactful for me. And one of the things that I thought about as you were sharing the SCAN piece of it, acronyms work, the local supportive partner, I think that having this mindset around, if you have, for example, I don't know, a Stop and Shop, that's one social determinant that we did not talk about in this, but in the future, we will talk about food security, because this is a huge, something that I'm personally passionate about, and something that we have to consider in these conversations. But, thinking about how you can partner with your local organizations. I mean, we go to the grocery store every day, for example, right? Can we talk to the manager about how they can provide provisions for families in their community that does not have enough food to eat, or those kinds of things. So I love that conversation. So thank you so much again, Jay, for that. And those who are in the breakout room for this topic will be able to dive deeper with Jay and ask questions. So we are going to move to our next speaker that will be talking about housing. And Alex Starpoli is the Director of Advocacy and Communications at the Fair Share Housing Center. Alex has spent her career dismantling systems of oppression at the intersection of public health and racial justice. She is currently the Director of Advocacy and Communications at the Fair Share Housing Center, where she uses her skills to advance policy change on the local, state, and federal levels. Prior to joining the Fair Share Housing Center, Alex worked as a policy consultant and strategist in New Jersey with clients including Salvation and Social Justice and Newark Community Street Team. Previously, she held positions at the Camden Coalition of Healthcare Providers, Drug Policy Alliance, the Maryland Governor's Office of Crime Control and Prevention, and the Coalition of Juvenile Justice. Alex completed her Bachelor of Science in Family Science and her Juris Doctor at the University of Maryland. She currently lives in Collingswood, New Jersey with her husband and 2 children. Welcome, Alex. Looking forward to hearing from you.
Thanks, Cecile. It's great to be here. Let me share my screen and we'll jump in. So thank you, everyone. Apologies, I was late. I missed the beginning, but it was great to hear, Jay, your presentation, and looking forward to talking a little bit more about housing. So jumping right in, this is sort of a quick overview of what I'll talk about. I'll give you a background in Fair Share Housing Center. We're coming from this as sort of an advocacy and policy organization. And so wanting to frame that conversation and get you all thinking about sort of the approach that we take. And I apologize, somebody just started doing the lawn outside, so hopefully you all can hear that. We'll talk a little bit about residential segregation and public health. We'll talk about housing related impacts on health. And then I wanted to give folks sort of an overview of the landscape of housing in New Jersey, because it's vast and sort of intimidating to kind of navigate. And so wanting to run through that with everybody. So Fair Share Housing Center, as I mentioned, we are an advocacy organization. Our focus is really on building diverse, integrated, and thriving communities in New Jersey. We were founded after the landmark civil rights case that established the Mount Laurel Doctrine in New Jersey, which I'll touch on a little bit later, but really thinking about how policies impact racial and economic discrimination in New Jersey, and how do we dismantle those and sort of create systems and structures where everybody is able to thrive. So again, we do this work in sort of 4 buckets. Our Creating Inclusive Communities work is really thinking about how do we create housing opportunities? So how do we enforce the Mount Laurel Doctrine to make sure that there's affordable housing in all communities? How do we make sure that affordable housing that we have is rehabilitated and preserved? Then we talk about safeguarding access to housing. So this is really where we think about, there might be brick and mortar housing, but there are a host of other policies that prevent people from actually accessing that housing. And so what do we do on a policy level to change those policies to make sure that people can get into housing? We have a bucket of work that includes equitable disaster relief. We won the largest fair housing case after Hurricane Sandy. So disaster relief wasn't being equitably dispersed to renters, primarily renters of color. And so we brought a federal fair housing lawsuit, and that remains still the biggest settlement in sort of history. And then we also think about addressing racial and economic disparities on a broader level. We recognize that housing is intersectional, right? There's a whole host of other social issues that are interrelated and connected, and we can't sort of work on housing in a vacuum. And so thinking about how housing relates to other issues. So I use this quote a lot from Richard Rothstein. Some of you might be familiar with The Color of Law, the book that he wrote that's really about how policy has explicitly created hyper-segregated regions. I think it's really impossible to talk about public health without talking about policy and segregation, right? You've heard a lot of what Jay talked about and sort of the need and issues with transportation barriers are because people live in places, right, where they don't have access to resources and what they need. And that is intentional, right? Government and private entities have created a web of systems and policies that are specifically designed to keep white people in power, right? And so that plays out across multiple systems of care, right? Especially in our healthcare system, but also in other systems, right? And so residential segregation isn't a mistake, it was intentional. And the results of residential segregation have impacts, widespread impacts, right? But particularly on health and well-being. And so when we think about whole people and how people can be and sort of live their fullest selves, we have to think about how their health and well-being is impacted by segregation. And in New Jersey, we are a hyper-segregated state, right? Most of you likely know this on this call, right? But we have some of the worst racial disparities across all indicators of health and well-being, right? And so despite being sort of a blue progressive Northeast state that people think of New Jersey as, right, we still have, we are still sort of the worst in a lot of things, including racial disparities, right, for maternal morbidity and mortality and infant morbidity and mortality. So thinking about sort of the impact of residential segregation on that, I think is super important. And one of our big buckets of work is enforcing the Mount Laurel Doctrine. So the Mount Laurel Doctrine is created through a series of Supreme Court decisions, New Jersey Supreme Court decisions, that prevent municipalities from passing policies that discriminate and keep out low-income people. We know that, you know, the case was brought under sort of low-income as like this protected category, but we know that low income often relates, especially in New Jersey, to people of color. And in Mount Laurel, the history of the case is that, as some of you might know, Mount Laurel in southern New Jersey had a historic Black community. There were locations in Mount Laurel that were part of the Underground Railroad. That community, as soon as sort of there was white flight out of the cities in sort of the 70s, that Black community was being pushed out of Mount Laurel as they were sort of starting to develop suburbs, right? And sort of these, what's the name? Like Levittown sort of towns, right? Like, you know, the same sort of house on a cul-de-sac, sort of stereotypical suburbs. And Ethel Lawrence, who was a school teacher in town, sort of organized people, and they came together to bring this case against the town, which ultimately said that, you know, they can't use exclusionary zoning to push out people who are low income, and that towns actually in New Jersey, based on our Constitution, have an affirmative requirement to provide realistic opportunities for the development of affordable housing. New Jersey is the only state in the country that has sort of this framework. There are a couple other states that have frameworks that are statutory, but because New Jersey is rooted in our Constitution, it makes it much, much stronger. And there is sort of statutory requirements as well that have come out of this series of cases. But it's important to know that we are sort of situated differently than other states. And so that's important context when we're thinking about housing and the availability of housing and all of that in New Jersey. So switching gears a little bit, just quickly running through what are the housing related impacts on health. I like to think of these in 4 buckets. There's some other research out there that puts them sort of in 3 buckets. And people sort of, right, you can conceptualize these all in your own way. But thinking about neighborhood, which is really this environment piece, right? Like where you live, affordability, stability, quality, and safety. So neighborhood, right? Up to 60% of your health is determined by where you live, right? We often hear that, you know, your zip code is an indicator of all these things. And so really thinking about what is the impact of that? You know, do you have access to food? Do you have access to transportation? Do you have access to good schools? Are you living next to an incinerator, right? There's all these factors about where you live that impact your health and obviously impact maternal health and child health and family health overall. Affordability is a big one, right? I think this is what we're hearing all about all the time. So affordable rent is considered 30% of a household income. This 2021 data is the most recent data. And so we know that nearly 1/3 of all US households and almost 50% of renter households in New Jersey are burdened, cost burdened by rent. So that's a large number of people, right, who are struggling to pay their rent. Obviously, increased spending on rent then translates to having less money to spend on other stuff, right? And so I think Jay hit on this too, right? Like your car breaks down, but you're paying an exorbitant amount for rent. You don't have the $500 to fix whatever broke in your car. And that sort of has this, you know, domino effect of all of these things, right? You can't get to your doctor appointment, you can't get to work, you can't pick up your kid from school. And so really thinking about housing as this large expense, right? Probably the largest household expense that folks have, what the impact of that is on other people. And then that financial strain, right, on physical and mental health as well. So here's a question for folks. Feel free to answer in the chat. So this should come as no surprise, right? We don't have enough affordable homes in New Jersey to meet the needs of all of our residents. Curious, how many more affordable homes do you all think we need to fill that gap? That's right. So as folks are saying, it is the largest number on here. So between 250,000 and 300,000 homes. So we have a significant gap of affordable homes. Some of this in part, and I'm not going to totally get into this because it'll take us sort of down a rabbit hole. Some of this in part is the Mount Laurel Doctrine that I mentioned before was unenforced for a period of around 15 years, sort of under the Christie administration and a little bit before that, which created a significant gap in affordable homes. And so we've been enforcing the Mount Laurel Doctrine successfully since 2015. And so New Jersey, actually in this sort of Northeast region, we are far surpassing New York, Connecticut, sort of Pennsylvania in producing affordable homes. And so we're building more than sort of our counterparts, but we're still just climbing out of such a hole that it feels almost impossible to sort of shrink this gap without other policies in place. So then thinking about stability, which I think also, right, is closely tied to affordability, right? But instability, including foreclosure, transients, which is, you know, people that are couch surfing or going from family home to family home, and then homelessness and eviction. I think the big part here to think about is really just the trauma of sort of living in a state of insecurity, right, and instability, and not knowing what's coming, and sort of what you're right, where you're sleeping tomorrow, and sort of that long-term impact on both like parent stress level, maternal stress level, child stress, right? All of those things really has a huge impact on health. And then finally, quality and safety. And so this is really thinking about habitability issues and sort of the environmental factors that are impacting people, right? So thinking about lead exposure, water contamination, living with vermin, right? What that impact is on a pregnant person, in addition to the impact on children and infants. And then I think, you know, thinking about sleep-related issues too, which, you know, I think we could probably have a whole conversation about what safe sleep is, which doesn't necessarily only mean a crib or a bassinet, which is a whole separate conversation. But however, either way, right, like thinking about sleeping conditions and what sort of other unsafe conditions in a home can mean to the impact in that way. So then switching gears a little bit to talk about the housing landscape in New Jersey. There are sort of these three different types of housing in New Jersey. And when I talk about types of housing, I'm really talking about brick and mortar. So there's market rate housing. This is where, you know, just typical, right? I'm going to look for an apartment, and an apartment, you know, one bedroom apartment somewhere in North Jersey is, you know, however much it costs, more than $2,000 a month. There's affordable housing, which is housing that is either, well, I'm not going to use that word. So affordable housing is housing that is specifically designated to be affordable, which usually means that they're getting some sort of tax credit. So LIHTC is low income housing tax credits. It's a federal program that's administered through the New Jersey Housing Mortgage and Finance Agency. So basically they're getting tax credits to build the housing. And then as a result of that, they're required to make the housing affordable. And there are a couple of other tax credit programs that aren't specifically LIHTC, but that also have similar requirements. And then there's Mount Laurel housing, as I was mentioned before. Based on this Mount Laurel doctrine, there is housing that's specifically developed as a result of agreements that Fair Share Housing Center has with towns, and the units in those buildings are required to be affordable. And that sort of happens in different ways. Some of the buildings are 100% affordable. Some of them are inclusionary buildings where there's market rate housing and then a certain percentage of affordable housing. But that Mount Laurel housing is unique to New Jersey. And so is important for people to know, because there's sort of, and I'll get into this, but there's a different application process for that type of housing. And so it's important for people to understand that. And then the third type of housing and affordable housing is public housing. So this is your typical, what folks would call Section 8 housing. And these are run by public housing authorities who get funding from HUD at the federal level to run those buildings. That's like the type of housing, thinking of, like I said, brick and mortar where people live. Then there are housing subsidies, right? So housing subsidies are specifically programs that help you pay rent. And you can use housing subsidies for both market rate housing and affordable housing. Public housing is sort of already subsidized, right? You're not going to use a voucher to access a public housing building. Housing subsidies come in sort of two forms, although project-based vouchers are sort of being phased out. But there are tenant-based vouchers and project-based vouchers. Tenant-based vouchers follow the person. So you as an individual get a voucher and you can sort of take that voucher wherever you want to live. Project-based vouchers have historically been attached to buildings. So I'm trying to think of an example. Like maybe I am, as Catholic Charities, let's say I own a building and I have 60 project-based vouchers for that building. And then as a tenant, you would apply and potentially get one of those vouchers for that building. But if you moved out of that apartment, the voucher wouldn't follow you. It's attached to the building. And then there's these different voucher types. So the most common are housing choice vouchers. There are SRAP vouchers, the state rental assistance program. There's special vouchers for veterans. And then I think there's like a couple of other ones, but knowing sort of that there's different types. These more specialty types are associated with supportive services. And so thinking about more wraparound supports that come with the voucher, not just sort of straight rental assistance. And then how do you apply for affordable housing? So this is the process. And some of this I put in here just so when you all have the, when you get the presentation afterwards, you'll have sort of like what to do. So Mount Laurel Housing, as I mentioned, has a unique application process that's separate from just applying to a typical market rate apartment. And so all affordable homes in New Jersey, sort of under the Mount Laurel doctrine, are required to be posted on the statewide website called the Housing Resource Center, which I have a link in at the end of this. And they are all required to, there's regulations that are governing sort of how they need to be marketed, what the rents are, all of these things. And so it's, like I said, it's a separate system, and you, instead of applying directly to the landlord, you have to be pre-approved. And so there are these folks that are called administrative agents that you have to submit an application to. If you meet the income requirements for the units, then you'll be entered into a lottery system. The wait list, as I'm sure you can imagine, for these homes are significant. It is a lottery system, but you sort of enter it. There was a building in Cherry Hill that sort of went online, and I think there were, I don't know, maybe 60 units available, and there were like upwards of 300, 400 applicants. And so there's high demand for them. but they're, you know, they are coming online every day, and they're affordable housing under Mount Laurel. There are rental opportunities, and then there are also for sale opportunities as well. There are fewer for sale, but there are. And so the Housing Resource Center is the primary way to find some of these. We also send out a newsletter once a month that has some of the ones that have deadlines sort of upcoming. And so if folks get on that list, we can share them as well. But I always like to share that this is sort of a different process so people understand that. So a little bit more about the Housing Choice Voucher Program. Some of you may be familiar that earlier this year, the Department of Community Affairs at the state level opened the voucher list. So there were 20,000 vouchers to give away and available, and more than 141 people applied for the program. So that just gives you a little insight too into just the sheer number of folks who are having housing issues in New Jersey. This is sort of the preference that was given. The other way to get vouchers is through local housing authorities, and then some organizations also have vouchers, and those are more supportive service vouchers. The other important information to know is that HUD just updated the fair market rents for 2024. So one of the things that we had commonly been hearing from folks is that even with a voucher, I can't find an apartment. Like the rents are just so high that the fair market rent rates for vouchers just weren't going far enough. So fair market rents are sort of what the value of your voucher is. That's based on, HUD sets these based on geographic location. And again, I think I put a link for this at the end so you could sort of see in New Jersey where the 2024 fair market rents fall. And then voucher recipients are required to sort of pay the difference in what the rent is. And so for a lot of folks, the voucher just doesn't go far enough, especially depending on where you live. And so the hope is that this increase will help more people access housing. And so we sort of have to see, right, the rental market and sort of the housing market is sort of crazy right now. And so I would imagine that there's still going to be some issues. And that's really sort of on the policy side, like what do we do as a state like New Jersey, where HUD is saying this is what the fair market rent is and this is what the voucher is. Like, should New Jersey be passing some sort of supplemental assistance to help people sort of reach what the rents are actually in our state? So here's another question for folks. We're going to turn to talk a little bit more about the homeless population and specifically. And so based on the 2023 point in time count, which New Jersey every year has to count the number of homeless people, point in time is sort of on a given night, which we know is not 100% accurate. Obviously, there are tons of people that don't get counted. It's an undercount. However, the 2023 point in time, New Jersey's homeless population grew by almost 20%. So how many homeless people do folks think were counted during this year's point in time count? So almost, so it was actually D. So 10,000, a little bit more than 10,000 people, which again, when we think of this and not think of, right, we know that this is an undercount. And so a significant number of people who are experiencing homelessness and sort of how do we address that and what do we do? And what I meant to mention at some point, I think I skipped over this, but when we think of housing, right, there's clearly a continuum. There are folks who are, living in sort of a homelessness situation. There are folks that are living in sort of an unstable position. And then there are folks who are in a more permanent situation, and sort of all of those impacts and health related impacts that we talked about, right, can impact people in that way at any time. And people move through sort of these different spaces. And so might need resources or different resources depending on what point and sort of what they're experiencing in the moment. And so when we think about individuals who are experiencing homelessness specifically, we also have to think about our local continuums of care. And folks may have heard of this term before, but the Department of Housing and Urban Development, so HUD on the federal level, has really encouraged local communities to work through their continuums of care to bring resources and nonprofits and local governments together to sort of, I like to describe it as like maximize the impact of sort of HUD programs. And so in practice, continuums of care are sort of groups of nonprofits that are coming together to say, like, I have 10 vouchers, I have 5 vouchers. They sort of come together, put all the vouchers in a pot, and have a coordinated, what's called a coordinated entry process, where people who are interested or need a voucher are sort of screened and then put on a list, essentially. And each continuum of care gets to sort of pick how they're going to do this, what populations they're going to prioritize. So it's definitely happening on a local level, and so you would have to sort of figure out, depending on where you are in the state, like who's convening the continuum of care and what does that look like. New Jersey has 16 continuums of care that cover the state, and so that's just another resource and another way for folks to get vouchers. I'm just looking at the chat. Qualify a person as homeless or unhoused. Yeah, I think, the answer in here that there's multiple definitions, that's accurate. I don't 100% know what like the technical like HUD definition of homelessness is. I would have to go back and look at it. But I think, exactly as Cayenne, I think that's how you pronounce your name, said, the problem with these definitions is that, again, they significantly undercount what we would, all more practically and realistically consider somebody as experiencing unstable housing. And so there's a distinction between sort of housing instability and homelessness, and being able to access certain services if you're just housing unstable versus actually meet the definition of homelessness, right? And so that's more of like on the policy level, how do we bridge that gap and make sure that people, right, like the like the no wrong door theory, right? Like that you don't necessarily have to meet a very specific definition to get access to services and resources. And then the other program I wanted to flag is the Department of Children and Families has a Keeping Families Together program that some of you might be familiar with. I think it's been around for a couple of years. I'm not super familiar with it, but I know I've sort of always heard about it. And then I happened to find that, again, I think I linked at the end, they just put out a brief in September of this year. And at the end, it sort of asked for comments from folks. And I think the deadline for that is sometime next week. And so I linked all of that again at the end of this presentation for folks who are interested, but it seems like they're looking for feedback on sort of their housing plan as a department. The other service, so that's talking about sort of vouchers and how do you access more permanent housing. Obviously, there are folks who are going to need emergency housing. The County Board of Social Services is really who administers emergency housing and sort of places folks at shelters or in hotels, if that's a safer option or a better option. And then the boards of social services also usually administer utility assistance. Sometimes it's outsourced to another agency, but they're the ones who can sort of help identify where you go. Yep, and as Cecile said, like 211 is definitely, if you call them, and they've really, I would say, over the last few years, like built out their housing section on 211. So there's a decent amount of information online as well for sort of where to go. But yeah, your county boards of social services is sort of the go-to for emergency assistance in this way. And then switching gears a little bit. So that's sort of like the housing landscape. I think it's important to talk about, I mentioned before, right, having access to brick and mortar is one thing, right? And like physically having units and having affordable units is important. But also making sure that people aren't kept out of those units because of other reasons is equally as important. So New Jersey has a law against discrimination. We have one of the strongest laws against discrimination in the country. We have, at least under the Murphy administration, we have a very strong division on civil rights within the Attorney General's office, who is charged with enforcing the law against discrimination. And so, you know, you can file a complaint if you believe you've been discriminated against. I think one of the most common issues we see in the housing space is around source of income. And the Division on Civil Rights has sort of done a lot of work in this area under the Murphy administration. Landlords are not allowed to discriminate based on source of income. So if you were paying with a voucher, they can't discriminate against you. And that often happens, right? We often hear from people like, I called up this landlord and they told me that they don't accept vouchers. That's illegal. And so knowing that and knowing your rights and how to navigate those spaces is important. The other tenant protection, and then there's these are not the only two tenant protections. These are the ones that I put on here. But the other big one that was just put in place a couple of years ago, it's been in effect for a couple of years, we worked on at Fair Share, is the Fair Chance in Housing Act. And so these are new protections in New Jersey, like I said, for a couple of years. They prevent landlords from asking about someone's prior criminal history on an initial housing application. So it's akin to sort of a ban the box, as you often see in the employment setting. Landlords are allowed to ask about criminal history after an initial offer of housing was made, but the law creates sort of a framework for what they can actually consider. They can't consider any arrests. They can only consider, it creates like a tiered framework with different look back periods based on the severity of the offense. And so again, it's just an added protection for tenants. We're the only state in the country that has this sort of protection. There are a lot of folks that are trying to get it on the statewide level. But so another one to keep in mind, and again, I'll make sure, I don't know if I actually put this in the resources, but I'll make sure that I link to the Division on Civil Rights, who has more information about these two laws specifically. And then the other protections that I know I put in the resources, Legal Services of New Jersey has a whole bunch of information about other tenant protections. So around eviction, around rent increases, around how to withhold rent for habitability issues. So there's, right, as you would imagine, there's a lot of things that can happen in a landlord-tenant situation. That's not our expertise at Fair Share Housing Center. But again, Legal Services of New Jersey has done a really great job of building out resources to explain sort of what those protections are so that folks know what their rights are. And so I would encourage people to take a look at that as well. Again, here's the resource page. And please get in touch if you have any questions. Always happy to chat. Always happy to hear about other barriers and issues that people are facing. We primarily operate on the policy level, and so are always interested to hear what's happening on the ground so that we can influence policy and hopefully change policy to impact people's lives. So thank you.
Thank you.
Sorry, I'm trying to unmute, struggling over there to unmute. Thank you so much, Alex, for that wonderful presentation, just to give us a level set and understand. I really love the quizzes in between to really strike a reality of what is really happening, right? It's very easy to become complacent or just not understand the reality that others are facing if you yourself are in a secure situation, right? And so I really appreciate that conversation, that part of the conversation. And there were some comments in the chat around, intimate partner violence being a leading cause of homelessness for women. And of course, if those women have children, that would be a similar situation, and perhaps having legal concerns with separating from children, as Erika shared in our breakout room as well, and being reunited with children. So these are all very connected issues, right? And so, yeah, we'll continue to have this conversation about this. I'm going to, in the chat, we have DV survivors can access and apply to victim of crime compensation that will help with relocation if you provide the proper documentation, like hospital documents, police orders, etc. And this is a great resource and something to think about in serving the people that you serve. So thank you, Chantel, for sharing that. You also have paid leave for domestic violence survivors, by the way. I didn't share that earlier, but that's something that if you are someone who is taking care of someone who has experienced intimate partner violence or has experienced it themselves and need to take time off for mental, emotional, physical healing, paid leave is an option as well. So that is something that you can look into. Oh, so with that, Corinne is going to put us into our groups, our breakout groups. So Corinne, I'll wait for you to.
Yep, just like before, we'll have 20 minutes in our breakout rooms. I broke up everyone based on their registration, so you should be moving into your breakout room shortly.
Got down. So I don't know what would you suggest the first step would be?
So reaching out. So definitely reaching out to different transportation companies and services, and just creating that proposition. For us, like Lyft reached out to us. It was like kind of out of the blue. But I'm definitely a huge advocate of do it yourself, just like starting that conversation. And it doesn't have to be like the ask. It's, hey, this is my organization. Here's what we do. I would love to create a relationship, a connection with you to learn more about what we do. So relationship building is always like the priority, because when and if something else does come up, then they actually have insight on who you are, what your demographic is, and then being able to provide like a collaborative solution to one of the services that you want to offer. You know what I mean? So organizations or businesses, they love to be able to be collaborative when it's possible, but it's easier to be collaborative with organizations that you already had a built relationship with, as opposed to kind of just being like, let me go on the internet and just pick one, right?
So true.
Mm-hmm.
I guess my follow-up question was, I don't know if Lyft has expanded the exception of Medicaid funding on Medicaid reimbursement. I know at the time that I was aware, it was only 6 states. Are we currently one of the states now? Have we been added on?
I believe so. I'm almost positive, because I do know, we work with Lyft, but I know Uber also does like the transportation rides for medical appointments. And there's Access-a-Ride and stuff, and all of those things are definitely covered under Medicaid. I'm almost positive, yes. But please don't quote me on it.
I'll reach out to just waiting for them to hit me back up. Thank you.
Yeah. And I will also say, like, looking at other transportation companies like Coach or these smaller bus companies, even ones that may seem like mom and pop, creating that kind of relationship and then offering them a different solution, so that they're still solving transportation as an issue, or solving the issue of transportation, but that might be a different area of revenue source that they didn't consider. It's like, oh, well, if you have a bunch of pregnant people and I can take my bus that fits 10 people, I can pick up these 10 women and then invoice you a smaller rate or whatever you negotiate, and then just create a new way to deal with that solution, or that problem.
Thank you so much. Thank you.
Yeah, sure. Mm-hmm.
I don't know if we missed, I perhaps missed the conversation about Medicaid, or missed a piece of it. So you are saying that Medicaid provides transportation in terms of what? Because I know that there's like a, I forgot the name of the
Access-a-Ride.
Okay, the bus thing that picks people up, you have to call. But you're also saying that Medicaid can provide more individualized transportation. Is that what we're saying? So what does that look like? Can you explain that to me?
So certain healthcare places like hospitals, certain hospitals have relationships with either Uber or Lyft, where they can call on behalf of the patient, and then it's billed to the patient's insurance, but typically it's Medicaid recipients that will receive that ride. Then there's also patients who are in different case management services. They also have access to transportation being covered under their Medicaid benefit. I believe there's also some like managed care plans that also participate in this, but that's more like insurance company specific. But I know I've had a conversation with someone at Aetna, and they were talking about that program, and I think AmeriHealth New Jersey also.
It would be great to know who those are, which ones do it. And, just provide that information to, doulas, community health workers, if they don't already know. I mean, it's new to me, new to my ears. I always knew about the bus, but I did not know that there was an individualized ability. Jamie, I see you raising your hand.
Hi, everybody. I'm Jamie Agunste. I work primarily in maternal mortality at Central Jersey Family Health Consortium. I was just reaching out to one of my friends who works at the, the Southern New Jersey Perinatal Cooperative, because I thought I remembered hearing from them one time that they arrange transportation, and my friend said that they do. So like reach out to the perinatal consortia in your area. I don't know, Judith, do you know if we do anything like that at Central?
No, we don't do anything. What we did for our program in particular, we had Uber Health. So when you was talking about, Jay, other things, yeah, we did Uber Health cards, but not as a whole on the consortium. No.
Right. Okay. I wasn't sure. I live in South Jersey, so it's, I wasn't sure exactly what, our organization does, but, Jay, to your point, like what you were talking about, it's so interesting. New Jersey is a really interesting place, right, for dealing with transportation issues. Like I'm from South Jersey, where, we have the largest, the highest pregnancy related mortality ratio, more women, we have a higher rate in New Jersey than anywhere else in the state. And, a lot of it is, it's like rural parts of the state, right? We've got, Cape May Regional that just closed. So we have people in Cape May who can't get to a birthing hospital, for like an hour, right? Which is crazy to me, because we've got almost 50 hospitals in the state that do labor and delivery and all of that stuff. So this is a really salient issue, and I'm so glad that you're addressing it. And, as somebody who was an inpatient nurse, I didn't you don't really kind of think about those things sometimes, right? You just see like, oh, the patient didn't go to our visits or all of that. And so it's, when you add this education and layer to nurses, I love today. This is a great day, Cecile, that you guys are doing this. So it's fantastic. The other thing I wanted to point out, and then I'll stop talking, is I did a talk the other day with a bunch of students in New Orleans, and I was talking to them. They were sociology and criminology students, and their instructor asked me to come in and talk about domestic violence and pregnancy and homicide. And we were talking about the intersection of, all of these new reproductive laws that are banning abortion. And in this town, the city that they were in was New Orleans, and abortion is not legal anymore, right, in Louisiana. And so I was doing some research ahead of time. And if somebody in New Orleans or Louisiana wants to get an abortion, they have to drive round trip a minimum of 700 to maybe 1,200 miles to access reproductive care like that. And, it really just made me think about how much, access to transportation and all of that really impact people's care, not just here, but everywhere else. I take some of those things for granted as somebody who, can just have such different access here, but then the access is not equitable around here. So thank you so much for this work.
Yeah, no, I'm very similar to you. So a lot of those same situations I went through with birthing my children, not even understanding that I was in these spaces of inequity. I just thought this is just what you have to do, right? So I'm also a nurse. I used to do community health. So when I worked at Callan Lord, I was there for more than 10 years, and looking at community health and the way that it's delivered versus a private office or a hospital is very vastly different, right? So community health centers are taking in patients regardless of their ability to pay, and you're not always able to control who walks in those doors. You just have to either be able to provide the care and then refer them out, or like deal with it in the moment, and then kind of, you know, decompress what happens, right? But what I learned from that, and what I've been applying to how we're building out the expansion and like the different capacity that melanated moms can have, I learned that you can't let that person's barrier stop you from actually helping them to create a solution. You know, I can always say like, oh, well, we don't do that, and then ship them away, right? But instead of saying that, I'm like, all right, well, that's not a service that I provide, but I do have a partnership with Christina. I do have a partnership with Dr. Judy. I do have a partnership with Dr. Jaye. So I know that they'll be able to make sure that you're still able to get the services that you need. So that just that warm handoff, it makes the person feel like they're actually valued, and they want to still continue to stay engaged with you. So, you know, when it comes to like transportation, like it made us so sad that Lyft stopped providing us with the vouchers for the moms, but for us to now be a part of their policy work so that we're able to change stuff on that macro level, it is way more impactful, even though it may not seem so on the individual level. You know what I mean? So I think when we're talking about it from that angle of like looking at community health versus the way that clinical or inpatient health is delivered, like we need to start having more of those conversations, because they do really go hand in hand. You know, what I'm telling the patient in a primary care visit in a clinic versus what they're hearing when they're inpatient is that can be vastly different, and it also can change their experience or their reluctance of engaging in, you know, the type of care that doesn't always respect them or doesn't give them the feeling of safety, you know, or stigmatizes them for their lifestyle or whatever, however they're marginalized. So I think like maybe that's the next thing we can work on, Cecile, is like pulling together more like community health and hospital partners to talk about how do we create that that integrated like healthcare system, and then again like understanding how that transportation can inhibit things, you know, because like I was saying, like with the crossing counties for things, when I had my kids, I lived in Hudson County and I delivered in Passaic County, and my doctor was very adamant, you cannot deliver at any hospital in this county, because I was very, very sick. And my first daughter, I actually delivered her in New York City. I never thought anything of like even seeking a hospital in New Jersey, even though that's where I resided. But that's where I lived. I mean, that's where I worked. So I'm like, okay, I'll go to wherever I work, and you know, it'll just work out that way. So we're not always aware of how people get to certain resources or how much it can impact the way that they're seeking care. And I know I didn't share it in the thing here, but like I ended up actually having a stillbirth, and when I had my stillbirth, I was actually on the train coming back to New Jersey, and I was, you know, seen at a hospital in New Jersey. The hospital in New Jersey did not contact my doctor in New York, so he had no idea anything even happened, and I was in the hospital for like 2 weeks. He had no idea anything happened until I called him and gave him the information. So like that disconnect, that whole like it's a lot, you know. So we have to be very cognizant of how those things impact a person's health and their ability to like be open and also participate in these healthcare systems, because they don't include them until they're ready to say that they're not compliant, right? I know that was a lot. I'm sorry.
No, this goes back to the conversation that we always bring up about trust and what trust is. And, you know, I'm always the one that's like, you know, there's the idea and then there's the process. So what does it mean to actually build trust, especially among communities where trust is constantly broken and has been for a very long time? And so, you know, that conversation is one that we need to definitely have. Jay, thank you for bringing that to the forefront, because I like to have those kinds of conversations where you can think about the real actions that people need to take, because you can't assume that people are just going to know. You know, I don't assume, it's the teacher in me. You got to walk people through the process. You can't just say, this is what must be done. So Janet, thank you.
Yes, hi, this is Dr. Jaye. Hi, Jay, how are you?
Hi, Dr. Jaye. I'm good. How are you?
I'm good. This has been really eye-opening this morning. This has been wonderful. The thing that kept going through my mind from the beginning when oh God, just went blank. Anyway, from when we were talking about barriers to getting care, I can remember so many days sitting in my office and a patient didn't show up, or they showed up and they were late. And like it was said, like Linda said, at the beginning, when they get to that first desk and someone says you're late, now, was there a problem? Can I help you?
Right.
I worked in the Bronx, which had an elevated train near my hospital. And if you think of an elevated train and you have a mom who either is pregnant, just had a baby, has a toddler with a stroller. She can't get up those steps. You know, we didn't have an elevator at that train in our area. There are other areas that have the elevator at the trains, but my area didn't. So right there, that was a big barrier for a lot of my clients. And the other thing is, when my patients didn't show up, I would call them, and thank God for telehealth, because I would call them to see how they're doing and what's up. And it could be a bad day. It could be raining, snowing, or they just couldn't get there for whatever reason. At least I could touch them that day. And we could make arrangements for a visit to come in, but at least that day I could assess them and follow up. And that's how you build trust, when they say, wow, my provider actually called me because I didn't show up. You know, but otherwise, what you would find on the chart, it would say patient non-compliant, absent from care for 3 visits or whatever. And you really have to sit and talk to your patients to find out what's going on, because so many things are going on. I'll call it behind the scenes that we don't know about.
Right.
And we have to take that extra time to try to connect with them and find out what can we do to help, referrals, like you said, you know. So this has been really wonderful. And hearing some of the like, I didn't know about the LIFT program. I haven't heard about that before. That's wonderful that now Medicaid is, you know, helping to pay for that.
I thank you for saying that, like, because I thought about the one time I'm not a doula, I am a nurse, but the one time I got to sit in with one of my moms and serve in the space for her as a doula, and really understanding my role as a nurse was completely different than what she needed in that time to support her. And I was able to like pay attention to like things I never would have looked at clinically, because that wasn't what I was trained to look for. Right. So I'm looking at this young girl. She's super nervous. She's shaking. They're just speaking at her to sign this paper, do this. This is what we're going to do. This. I was like, y'all need to wait. You can't, or you're not paying attention to the fact that this girl is like literally shaking. She doesn't know what's going on. And it was completely over their head. Well, you know, she's had kids before, so this and this. And I'm like, that has nothing to do with right now. You know, so it gave me, like, not that I didn't appreciate doulas, but it gave me such a bigger appreciation for what doulas do in that birthing time, where they're able to really connect with that mom, a birthing person, in an emotional way, so that they're not just a procedure, right? Like, this is a whole experience for her and for that baby. But if nobody is paying attention to that piece, other things can happen, right? And like with this young lady, one of the things she kept saying is, I can't handle having any more kids. She had 3 babies in less than 3 years. She suffered a lot of significant loss. She's like, I don't have the support. I'm really scared. Please don't make me do this again. Can y'all tie my tubes? And the doctor came in and said, well, because you were non-compliant, you didn't come to the last appointment, we can't do it. And they didn't tie her tubes, and she ended up getting pregnant like 4 months later. And she just felt trapped. And I'm like, yo, you don't understand your ability to hear this woman out when she's telling you this is the support that she needs should supersede the procedure that you want to enforce by condemning her or putting her in another compromising situation where she has no other.
What does not going to an appointment have to do with not wanting to have a baby again? Like, what is logic? There's literally no logic.
Yeah,
that's actually,
I don't know what the
actually a law
situation
in New Jersey, I think. There's like because they don't want reproductive, and this is my understanding of it.
Coercion.
Sorry, the conversation was getting hot in our group, and we we
got kicked out. No, I'll just finish the one thought, and Dr. Jaye, maybe you can add to it. There's a law about like there has to be 30 days, right? 30 days. Somebody has to have a signature and a consent 30 days before they get a procedure like that, right, Dr. Jaye? So that they can't just be coerced on the spot. But that does create issues, right, for people who can't or don't have access to prenatal care. Like, it creates a real conundrum.
But as a provider, what I would have done with this young lady if she hadn't signed the papers in time was to offer her something to bridge her over till she signed the papers
100%.
and had 30 days. She
Totally.
could have had, she could have asked for an IUD. She could have been put on, Depo or something. Depo would have gave her 3 months right there.
Yeah. Not to like start all this, but like to understand, like when Linda was speaking earlier about IPV, we have to remember that there are so many other factors that can influence a way that someone is able to make that kind of decision. And in that case, particularly, she was dealing with IPV. She was dealing with an abusive partner who also had substance abuse. She was dealing with being unhoused because of all of this.
Mm-hmm.
She was going into her prenatal appointments with physical signs of abuse, and no one said anything. Wow. So it's like you're watching this happen, and then you're still going to condemn her by telling her, "Yeah, we're not going to do that. So you're bad." But these are systems that we have to pay more attention to, and we have to humanize them instead of continuing to just be objective. And I know it's very difficult, and I'm even just speaking as a nurse. That's how you think. Everything is supposed to be objective so you can take away your bias, but it actually creates a bigger bias when you do that, because you're not paying attention to the fact that this human is experiencing something, not the object is having a procedure. You know what I mean?
Right.
All right, I'll get off my soapbox. I'm sorry, y'all.
Thank you. No, thank you. That was a great clarification, because I didn't know, that's why I asked the question, like, wait a minute, that doesn't make sense in my very, certain, my brain.
I should have been in that room, I guess, huh?
Yes, definitely. And we could clone ourselves. We can be in all the rooms. So we are going to now do share out. So I will have the transportation group share out first. Whomever would like to share anything that they learned or discussed in the group.
I'll share something that Jaye, I asked just based on in my own organization when we're working on providing transportation to our own clients. And something that really stuck out to me that she said was creating a relationship, like just relationship building. This is what we do. How can I help you versus, this is what I need and this is how can you help me? So I appreciated that.
I'm just going to tag on to what Christina said, because I was going to add to that as well with the relationship building. And one of the things that was brought out, Jaye mentioned organizations that you have a relationship with, tend to be more congruent to you working with them than ones that are not. Not to say that you can't, but depends on, also the time frame you want this to be accomplished and to get it done. It's quicker to know someone that could execute it more effectively than someone that you're trying to build blocks with.
And I think the one thing that I heard that I thought was really important is being consciously aware of the barriers that your clients have to go through to get to a particular location, because I think that we sometimes just make assumptions in our care provision that, well, they're just not coming. But I think it's even more than that. And I love what Janet said about doing a telehealth, like reach out and touch when they don't come, because I think that is the barrier breaker that allows for people to know, well, I didn't get there, but look, they called me. I'm important enough to make sure that I'm cared for in spite of what barrier that I could not get through. And I'm from Texas, and Houston, Texas at that, which has one of the largest medical centers, I think, in the world from what I've heard. And so I could walk to 15 hospitals from my house. And so it's amazing to think, don't remember who said it, but it's an hour to get to, Jamie said, takes an hour to get to a birthing hospital. And the fact that the deserts for medical care is equally as significant as a desert for food care or food deserts, and the things that we take for granted as individuals who have access to it in any way, shape, or form. It's just kind of it's important for us to get incumbent upon us to be really a lot more aware of what's happening with our clients and what's happening with the community, so we can do the policy changing that Jay was talking about, and we can do the reach out that Janet was talking about, so that there is much more connectedness between us and the people that we're serving.
Affordable housing that's being built is for special needs population. That includes folks with developmental and intellectual disabilities, as well as senior housing. I'm trying to think if there are any other special populations. I think that those are the only two right now. I think you raised an interesting question of like whether mothers or like families with small children like should be its own population, right? Like we think of family housing more broadly, but I don't know if that's the type of housing you're talking about, or if you're talking about there are vouchers, I believe, that are specific to certain special populations as well.
Right, the vouchers that are specific to an adult with mental health.
So can I interject?
Yes,
There
ma'am.
are vouchers through the Division of Mental Health and Addiction Services.
Right.
Specifically for that population. And I believe there may be available vouchers right now, but that's something that you would have to inquire about from the division.
Right. Are you familiar with, I think it's Harry Reyes?
Yes, I am.
Okay, yes. So he did a presentation, and I think I'm just trying to follow up on that because he has spoke about the vouchers for people that have mental illness.
Yes, he's the point person.
Okay. All right. So I'll follow up with him. Thank you, Erika.
You're welcome.
All right.
Any other questions or comments?
I just had a question about the fair market rent values and just like how they are determined. I know they come out with them every year, but as someone that has worked in like homeless prevention and stuff, the client, they have to end up paying the difference if their rent is over the fair market value. And yeah, it's like it's hard to even find an apartment in New Jersey that is affordable.
Yeah, it's definitely one of the challenges. I don't know specifically like what they use to calculate them. It's definitely based on census data in some way, and then a bunch of other factors, right? Like market factors. I'm trying to look up if they have an actual how they determine them. But yeah, I mean, I think that this is a growing, right? Like it's an ongoing problem. It's always been a problem. I think it's been more, I mean, it's been exacerbated, I would say, since COVID and sort of the housing surge that we've seen in New Jersey. There's been a huge influx of people moving to New Jersey from other places, primarily New York, and sort of moving into the New Jersey suburbs. And that has impacted our housing stock, housing rental prices, all of the sort of issues with having more people and a higher demand and not enough housing stock. And so it continues to be an issue. We have advocated with the administration for some time to sort of have supplemental assistance. I think that there's hope that the 2024 numbers would bridge some of that gap, right? Because they're increasing the voucher amount, but it's likely that the rental prices will continue to rise, right? And so the problem will continue to sort of remain the same. And so I think, continued advocacy and talking about it and really identifying the issue as one, which is what got HUD to increase the fair market rent, right? Because they were hearing from folks all around the country that it just wasn't enough.
Thank you.
And it looks like Isabel has her hand up.
Yes, hi. Okay. For example, I have this client, right? She has 8 kids and she has a voucher, but she lives in an apartment in a really bad condition. It's so she needs to move, but it's been hard for her to find an apartment. I don't know how to help her. I don't know where to go because I already knocked a couple of doors and it's like, no, like I don't know if you guys have any other source that I can get an apartment. She has a voucher and she has corporate, she has a health insurance and all that. But she needs to move and she just had twins.
Yeah, I think, Isabel, unfortunately, what you're identifying is a common issue and is one of the challenges that I think a lot of people with vouchers are facing, right? That there isn't enough housing stock. So I think there's sort of two things. I think one is it that she can't find any housing stock, or is she being turned away for some reason, to identify whether there's some wrongdoing on the part of a landlord, like in that situation, which doesn't necessarily immediately help with getting her into a place. But I think identifying whether that's the barrier, or is it that there's no housing stock that she can afford. And then the other thing that I would recommend, and again, like this isn't what we do day in and day out. So like there are other folks that I could connect you to that would better be able to help you. But I think depending on where you are in the state or where she is in the state, really figuring out who are the folks that are working in the housing space in that area? Is there anybody that sort of is able to identify, like, these are landlords who do accept, right, like, or friendly towards voucher holders and might have availability. But trying, I don't really have any better advice than that. I don't know if anybody else on the phone does, but I think what you're identifying is it's a common barrier for folks.
Yeah, okay,
Well,
thank you.
I know if there's like a habitability issue, that like the person that's renting the apartment, they're supposed to still pay their rent, but put it in like an escrow account and then, go to court and stuff like that, which is just a lot to do, really, just like fighting with the landlord and stuff about, making improvements to the apartment.
Yeah, Erika I don't know if Erika, you want to jump in on that. Like there's definitely, right, like, yeah, like legal things that if there is habitability issues, I don't know that addresses the immediate, right? Like that doesn't necessarily address the immediate need if the person wants to move anyway.
So in terms of habitability, I mean, there are options that we can take in terms of what an individual can do. I mean, and I think if you're dealing with habitability issues, they need to see an attorney right away. You need to refer them to an attorney because what tends to happen is that they withhold rent. And in order to make a habitability defense in a non-payment of rent case in court, you have to post all the rent money in court. And what we find is many tenants will spend that money and then they're out of luck and they can be evicted for non-payment of rent. And the judge won't even hear them out. It's called a Marini defense. The judge won't even hear them out on the deplorable conditions in the apartment. So, they can withhold rent and force the landlord to make repairs. What usually happens, the landlord will take them to court and then the judge will determine what repairs need to be made or what the abatement in rent should be. Sometimes they'll use that rent money to make repairs on their own, so they need to keep receipts. And that's very, very risky to do that because the judge may not agree with you. And again, you have to post all the rent money. So that's not something that we advise. So it is very fact specific and based on the circumstances of the tenant. So in that situation, if you're dealing with bad housing conditions, they need to see an attorney right away because they may be dealing with an eviction and they may be dealing with obviously health issues if there are obviously health concerns in the apartment, mold, lead, whatever it is. We deal with that all the time. And that's a huge issue in the populations that we serve.
I think somebody had another hand up, but I think it went down.
Yes, I was just gonna bring up an issue I think that is often left behind. There's we talk a lot about diversion and prevention, but I think a part of it that they won't speak about is when people do get to a place where they're able to kind of be self-sufficient, but they're not quite, and there's really no programs to kind of hold them there. So they end up going back into the homeless system. And I know that some of the very rules, the fair market rent, technically you're not allowed to pay the difference on your own, right? You're supposed to find something. And so it becomes a lot of fair, because if my rent is $50 over and I can afford it, I have to make sure the landlord is willing to put the lower amount on the lease, and then I pay the difference. And it can cause so many issues where actually the tenant can be at risk of losing their housing for doing something like that. And if you fight a landlord, especially as a voucher holder, the next thing that happens, seen it happen over and over, they push to get you out of the apartment. And then you want to get out because it's uncomfortable. I'm no longer feeling safe and at home in my home. So are there any policies being addressed in new laws coming out around kind of that space? Not just, landlords should do this, don't withhold rent, but around spaces like that where landlords, it's happening a lot more often than I think we're seeing. Landlords are trying to get tenants out, and they don't even know if there any legal recourse for them. They don't own rent. They may be a voucher holder usually, but the landlord wants to get more for the apartment. So are there any legal things around that you can do to kind of protect yourself?
Erika, do you want to jump in there? I feel like we're entering
The question is that there's a voucher, but the landlord wants to raise the rent beyond what's permitted?
Yes. And some landlords honestly no longer want a voucher holder in there, but they're legally not allowed to say that. Know what I mean?
So we deal with that too. We just had a similar case where the landlord tried to raise the rent, and basically took our client to court, saying that they're obligated to pay the increase in rent, which was not the case. That's really between the landlord and the agency that issues the voucher, whether it's Section 8, rental assistance, whatever it may be. And they have to kind of work it out. And if the agency doesn't agree with the increase, if it's way too much, then the tenant may have to move, and they would be issued a moving voucher. I want to let you know that the tenant is only can only be evicted for non-payment of their portion of the rent, cannot be evicted for non-payment of what the agency is supposed to pay. So they're usually paying 30% of their income. That's the only obligation. Unless what we find is, the voucher is terminated for some reason, and we deal with those issues too. So if you come across that where the landlord tries to increase the rent above what's permitted or allowed or approved by the agency, and tries to hold the tenant responsible, takes them to court, again, it's imperative that person gets legal services right away. So you could see how obviously legal services is necessary in all these situations.
Thank you. It's just, I think that they get lost a little bit in the flow, where it's not necessarily non-payment or the usual issue, but landlords have gotten really crafty to try to go around some of those fair housing rules to not, they can't say, I don't want to rent to you because you're a voucher holder, or I want to charge more. So they try so many different tricks. And many people don't know to go to a lawyer, or they don't have a clue that they have rights. So they end up going into crisis trying to move.
Yeah, that's the unfortunate part. Again, the demand for these types of services is way greater than the resources that are available. We're actually working on, we have probably 50 or 60 tenants now in Ocean County that are fighting a rent increase. Even though there's a rent control ordinance that was put in place. So again, these issues crop up all the time around the state.
Any other questions or comments?
There's a question from one of our registrants asking, how can we help our clients utilize Medicaid funding for housing?
Yeah, I mean, I think that that's another good one. And Erika might know more about this. I know that the state was applying for the waiver to actually be able to use housing, to use Medicaid dollars to actually pay for housing. Erika, I see you nod your head, so I'm gonna let you answer.
Yes, so the Medicaid waiver demonstration, so the state is currently working on developing that and operationalizing that. And we've been a part of those work groups discussions, and yes, very positive in terms of the fact that they included housing supports in the Medicaid waiver demonstration. Okay, so that's been included, and now we are having discussions about what that looks like, eligibility criteria, what services specifically, how people are going to be referred. That's all in discussions, and they're actually happening as we speak, you know, in these next couple of weeks. They've already started already. What's also promising is that they've included legal services in terms of housing supports, included in housing supports, and what that's going to look like. So that's going to be embedded in the housing supports. And what my understanding is that there's the MCOs, or I'm sorry, at the Medicaid office, there's going to be a hub, a housing supports hub. And this is really at the beginning stages of how this is going to work. And they are looking for feedback from stakeholders, which we're a part of, about what this is going to look like, how referrals are going to be made, who's going to be eligible. But yes, it looks like we're getting to the point where Medicaid will be paying for housing support services. That means case management, legal services, helping people lease up, helping them understand their rights. So that hopefully we're on a positive trajectory with Medicaid and housing supports. So that's definitely positive. So we'll have to wait and see. I mean, they said that, hopefully at the beginning, I'm sorry, maybe December 2024, we'll know more. And, it'll take a good year to really get this underway.
Great. Well, we have a couple of seconds left. So if there are any last quick comments or anything, please feel free to say them now. Great. Well, thank you so much, everyone. Thank you, Alex and Erika. And we'll see you in the main room shortly.
Sorry, the conversation was getting hot in our group, and we
we got kicked out. No, I'll just finish the one thought, and Dr. Jaye, maybe you can add to it. There's a law about there has to be 30 days, right? 30 days. Somebody has to have a signature and a consent 30 days before they get a procedure like that, right, Dr. Jaye? So that they can't just be coerced on the spot. But that does create issues, right, for people who can't or don't have access to prenatal care. It creates a real conundrum.
But as a provider, what I would have done with this young lady, if she hadn't signed the papers in time, was to offer her something to bridge her over till she signed the papers.
100%.
30
yep.
days. She could have had, she could have asked for an IUD. She could have been put on the, depot or something. Depot would have gave her 3 months right there.
Yeah. Not to start all this, but to understand when Linda was speaking earlier about IPV, you know, we have to remember that there's so many other factors that can influence a way that someone is able to make that kind of decision. And in
Correct.
that case, particularly, she was dealing with IPV. She was dealing with an abusive partner who also had substance abuse. She was dealing with being unhoused because of all of this. She was going into her prenatal appointments with signs of physical signs of abuse, and no one said anything. So it's like, you're watching this happen, and then you're still going to condemn her by telling her, yeah, we're not going to do that, so you're bad. You know, but these are systems that we have to pay more attention to, and we have to humanize them instead of continuing to just be objective. And I know it's very difficult, and I'm even just speaking as a nurse, that's how you think. Everything is supposed to be objective so you can take away your bias, but it actually creates a bigger bias when you do that, because you're not paying attention to the fact that this human is experiencing something, not the object is having a procedure. You know what I mean?
Right.
All right, I'll get off my soapbox. I'm sorry, y'all.
Thank you. No, thank you. That was a great clarification, because I didn't know, you know, that's why I asked the question, like, wait a minute, that doesn't make sense in my very, you know, certain, my brain. So
I should have been in that room, I guess, huh?
Yes, definitely. And we could clone ourselves. We could be in all the rooms. But yeah, so we are going to now do share outs. So I will have the transportation group share out first. Whomever would like to share anything that they learned or discussed in the group.
I'll share something that Jaye, I asked just based on my own organization when we're working on providing transportation to our own clients. And something that really stuck out to me that she said was creating a relationship, like just relationship building. This is what we do, how can I help you versus, you know, this is what I need and this is how can you help me? So I appreciated that.
I'm just going to tag on to what Christina said, because I was going to add to that as well with the relationship building. And one of the things that was brought out, Jay mentioned organizations that you have a relationship with, you know, tend to be more congruent to you working with them than ones that are not. Not to say that you can't, but depends on, you know, also the time frame you want this to be accomplished and to get it done. You know, it's quicker to know someone that could execute it more effectively than someone that you're trying to build blocks with.
And I think the one thing that I heard that I thought was really important is being consciously aware of the barriers that your clients have to go through to get to a particular location, because I think that we sometimes just make assumptions in our care provision that, well, they're just not coming. But I think it's even more than that. And I love what Janet said about doing a telehealth, like reach out and touch when they don't come, because I think that is the barrier breaker that allows for people to know, well, I didn't get there, but look, they called me. I'm important enough to make sure that I'm cared for in spite of what barrier that I could not get through. And I'm from Texas, and Houston, Texas at that, which has one of the largest medical centers, I think, in the world from what I've heard. And so I could walk to 15 hospitals from my house. And so it's amazing to think, don't remember who said it, but it's an hour to get to, Jamie said, takes an hour to get to a birthing hospital. And the fact that the deserts for medical care is equally as significant as a desert for food care or food deserts, and the things that we take for granted as individuals who have access to it in any way, shape, or form. It's just kind of it's important for us to get incumbent upon us to be really a lot more aware of what's happening with our clients and what's happening with the community, so we can do the policy changing that Jay was talking about, and we can do the reach out that Janet was talking about, so that there is much more connectedness between us and the people that we're serving.
Absolutely. Yeah, there's others, but the sheet that we collected notes on will be shared with the group. You're going to get a lot of stuff shared, but hopefully you utilize them when you get them. So with that, I want to make sure that the other group on housing has time to share, to discuss what they shared or talked about in their group as well.
I can sort of give an overview, and then if folks want to jump in individually, I think that I just want to thank Erika, because I think a lot of the issues that came up in the housing group are really like, what are the legal issues that residents face and tenants face, and just the acknowledgement that there are not enough legal services, right, to go around, or people don't know about sort of where they can access them and what are the entry points, or that they're, you know, something's happening to them that they could take legal action potentially. And so that was definitely an overarching theme. And then I think, you know, this issue of affordability and sort of, you know, even if you have a voucher and really limited options on where to go. And I think that that's an ongoing issue that, you know, really we've been seeing since, you know, pre-COVID, but I think particularly since COVID, and especially since sort of eviction assistance programs have run out, and what that means for people. And we've sort of always warned of sort of like this cliff that's coming. And I think we were able to head that off in a lot of ways because of programs that we got put in place, but is still really impacting people, just the affordability crisis in general.
A question about housing that I wanted to bring up earlier. Is there a way to provide, like have a cap on what landlords can charge for rent?
Yeah.
Like, I just feel like it becomes a gouging situation, right? You know that New Jersey is expensive. So if you live in a certain area, you have, and it doesn't even have to be in a certain area. It's expensive everywhere.
So there are, you know, you'll hear a lot of people talk about statewide rent control. I think that there's, I think thinking about statewide rent control would be very, very difficult, right? New Jersey has a wide range of rental markets within our state. And so figuring that out from a policy perspective, I think is challenging. There are some localities in New Jersey that do have rent control. And then there are laws about rent increases, right? And that are actionable depending on what a landlord is trying to do, which doesn't address the sort of initial rent, but addresses it once folks are in the home. So I think, you know, that's an ongoing conversation, right? And thinking about rent control, like, is that a local issue that like we should be doing things on a local level, or should we be doing something on the state level, and thinking through that. And then I'm just looking at Jaye's question about home ownership. Yeah, so we've done a lot of work around home ownership in New Jersey, actually in the state's most recent budget that passed this year. There's, for the first time, a first generation home ownership program. So New Jersey, folks might be familiar, has a first time home buyer program, but what we were really seeing in the data that was going mostly to white families or white individuals. And so we wanted to really think about what a first generation home ownership would look like. And so there was money in this budget for that. And we're in the process now of working with the Housing, Mortgage, and Finance Agency to design what that program would look like. But the idea that the home buyer would be a first generation, right? So nobody in their family previously had owned a home, and right, we're still working out what that exact definition is. But yeah, definitely. I mean, there's still a lot more work to be done in that area, but really thinking about how do we address generational wealth and start to close that gap, right? New Jersey has one of the largest racial wealth gaps in the country between Black and white people. And then I think for Latino, it's like second or third in the country. And so, you know, really thinking about what are the ways, right? Home ownership is the primary way that people accumulate wealth. And so what does that look like?
Absolutely. Thank you so much for the level of expertise on these conversations is so fantastic. And I hope that everyone, you know, got something out of this. And we are going to be moving into closing. So Karen shared a Jam board on in the chat, where you would talk about how you plan to apply today's learnings to your work, or if you have any questions and to the communities that you serve, if there's any specific way that you can think about fostering moving this conversation forward. We would absolutely love to hear about it. So this is just the opportunity to take a few moments to click on that and let us know if you have any issues with accessing that and using it. If you've never used it, you basically click on it and then you click on the Jamboard and you can type in your response there. So we'll give a few moments. It's 12, well, my clock says 12:46, so maybe about 5 minutes before we close out. So at 12:51, we can come back to the official closing out. And I just want to extend loads of gratitude to Linda Locke, Alex Starpoli, Erika Kerber, and Jaye Wilson for coming and sharing their expertise and their experiences in these areas. And I'm looking forward to more partnerships and more conversation around how we can utilize this information in our work, in our daily work, and how we can, again, be champions of thinking about this as a part of really getting to the bottom of this maternal mortality issue in New Jersey. And so with that, the New Jersey Birth Equity Funders Alliance thanks you. And we look forward to sharing with you more information and being in community with you going forward. So thank you again for joining us. And we look forward to seeing you another time.
Thank you.
Thank you.
But, you know.
We know we were here.